Yes, I am also okay. My screen is visible on your phone also. Yeah. Hello, guys. Can you hear me?
Yes, sir, we are able to hear you.
Okay. Okay. Wonderful. So we are all here now in the ICU, and can you span the camera around? So Dr. Srikanth is now going to explain to us how we use ECMO with a bit of modification for starting a normothermic regional perfusion. So we have the experts, all are here from all parts of India, and we have Dr. Philip who's here from US. So at any time, any of the experts, please pitch in. The audio is only with me, so we'll pass the audio to you. So Srikanth, over to you. Yes. Explain to them the situation, and you want to start with the DCD4 situation. Your choice.
Yeah, DCD4, we can just start with that.
Okay,
so
so-
DCD4 is a brain dead patient whose one set has been done, and before the second set has been done, the patient has become unstable, right? So second set is not possible because apnea is not possible in those cases, and it starts to deteriorate and rapidly start to go down. So that's where DCD4 will come. Now, in an Indian setup, most of the withdrawal, or even for DCD4, that's DCD3 and 4, will be done predominantly in the ICU. That's what I presume, because given the unique dynamics, it's not as if the attendants are very willing, very eager to donate organs. So there is a continuous kind of a interaction between the grief counselor and the attendants, and finally they come to an agreement for at least the interest to donate organs. So what I presume is that most of the things the interactions may be have in the ICU itself. There's another option which is in the OT. We'll take that later, but I'll just talk about how in the ICU. So in the ICU,
take the mic from you. You need both your hands.
In the ICU, it's the stuff first. In the ICU, we're going to be using ECMO CPB, which has been assembled. See, the ECMO machine and its circuit is extremely expensive and available issue nowadays. So we have created what's like a hybrid low-cost ECMO CPB machine. So I'll just take you through the entire part of it. So it's got, as you can all see,
use both hands. Yeah.
It's got a tube or a venous line which sort of draws the blood, and this is the red, which is the arterial line which pushes the blood back. Now, if we just follow the venous line, how do we drain out the blood? First and foremost, we use two cannulas.
So let's start with the cannula. You have with you? So let's start with what cannula we're going to use.
So we have the femoral vein, the femoral artery, and the contralateral femoral artery. These are the three vessels that need to be addressed. When the patient's BP starts to go down below a critical level, and the patient is either for withdrawal of life support or DCD4, what we will be doing before the patient cardiac activity comes to a standstill, we are going to be cannulating the femoral vein on one side, the femoral artery on the same side, and the femoral artery on the opposite side. So we'll be putting a small sheath in all the three vessels. As the BP is going down, we are going to be heparinizing the patient. We'll be giving 30,000 units of heparin pre-mortem, right? Once the heart comes to a standstill, then 5 minutes of no touch time. And once all this thing is done, immediately over the sheath, we are going to be these are the sheets we are putting it beforehand, and once the patient has a flat line and the attendants have gone out, we're going to be rapidly putting these three guide wires into the three sheets. So this
Can
one,
we just show it?
Yeah.
Open the sheet and show it.
I don't want to open it.
We will do it again. Huh?
Okay.
The demo is for live. We need to show everything. We can open it. We can always spend some money.
We cannulate under real-time ultrasound guidance so that we know which vessel we are.
Any comments from any expert, please chip in.
One in the contralateral side. Okay. So these three things are there already. So once the patient has
The consent of family has already been taken for DCD, and the consent includes that we will have these in place. It's a part of the signature.
16 gauge.
You'll have for DVD again, but after that it starts collapsing.
Yeah, so
Comes for DCD again.
again, because our consent for that is slightly different, so we'll have to explain to them. So this is basically for a very motivated family who want to donate. And Kumud, yes.
Yeah.
Just to say, what is the timeline? Because this patient is just acutely deteriorated. You have a DBD consent that is on the proviso of a positive first and second apnea test. You only have the first one. At what stage are you going to get the DCD consent done?
So as soon as the blood pressure sustained remains below systolic of 80, and I know that this patient started to go down rapidly, that's the time we'll start to engage the patient's attendant. That is, the heart comes to a standstill beforehand, or the patient becomes extremely unstable for a second apnea. Would you be okay with going ahead and retrieving the organs through DCD? So that's the time when we'll start engaging, because the decision-making process also takes time. Yes. I mean, everything.
So
I think let us talk about the consent later. Let us
Technical.
talk about the technical.
So we have three 16 gauge in place.
3 16 gauge cannulas in all three, and we have left the patient alone. We have given 30,000 units of heparin. The attendants wait for 5 minutes. We go away. Immediately we start putting the guide wires to this. So 3 guide wires to this. And the guide wire go. Dilators. So we're going to put a 23 gauge venous access line, and we're going to have a 18 gauge return arterial. So
On the right
Can
side.
open and show.
both on the right sides. Okay, so
Keep opening and showing. We will share the list of equipment that you need 1, 2, 3, 4, 20, 30 with everybody.
Sharing a video.
So I will.
I don't think so. You can make your own.
And rapidly insert the venous line.
Because we can make some teaching
The tip of the venous
videos.
line is just beyond the hepatic vein. That's normally where we keep it. Just beyond. Some people keep it at the level. Some people keep it just beyond.
The venous one.
The venous one. Okay, this is 23 gauge.
Do you then have a Yamaha?
No, we have an ultrasound which sees that we actually place the position on the side. We have placed the lines also on ultrasound guidance. So we can see the tip exactly where it's supposed to be. Okay. We put in arterial line on same side.
This will go up to your time.
Yeah, you just go up to that. That's about it. Okay. There.
How much French?
This is around this is 17 French. This is 17 French. 17 French, 23 French. But there's a range of 8 to 20. The opposite. This
Is Jumanna listening?
is a 14 French sheet. Why the 14 French is
Yes,
because
sir, I'm listening.
Hi.
balloon.
Just a second. Jumanna is here from Mumbai. So, yeah. What is the size of cannula that you would recommend for arterial and venous?
We had thought of going with 17, 19, maximum 21. The reason being we want to do this smoothly without, really struggling with cannulation. So,
Okay.
The standard recommendation, treating all patients alike, is a 19 arterial, 25 venous.
25 venous.
Okay. So 19 arterial, 25
The
venous.
reason why 25 venous is it's a passive flow, right? So the larger the bore, the better the flow.
Low volume.
It's a low volume flow. Larger the bore, the better the flow. Okay, the arterial is an active push, so you can have a smaller gauge cannula.
yeah. So recommended that we keep a little smaller arterial so that we don't kind of lose that access.
So from here, we're going to be inserting this. We have already seen the measurement from here to say like the way we measure.
Correct.
Right? For an IBP also we measure to the sternal notch. So you can measure to that level. That will be around the mid thoracic level.
Correct.
Right? And you insert it through the sheath.
Okay.
And inflate it.
So we have managed to find a balloon thanks to our vascular surgery team in Manipal.
This balloon,
So this is a Reliance balloon. It has a maximum diameter of 46 millimeters. And we have a chart that how much ml of contrast. Do we have contrast
yes,
here?
we have contrast there.
So we will use about 1/3 contrast and 2/3 water to fill it up.
Inflating around. So I'm just holding it so that you can see what balloon. It will be enough. It will be inflating it with OMDP. So we can see
See it.
See, but that's just for a confirmation. That's not going to stop our procedure.
Correct.
Right? We don't wait for the C
Yeah.
arm and come in.
Yes.
It won't be a C arm there because the beds don't allow for a C arm.
Correct.
So it's going to be an X-ray.
X-ray.
Right?
Just
So
to confirm.
that's just to confirm.
Yes.
Right?
Come forward. You can go slow. Huh?
At what level? With thoracic level is what.
So you also have the check that there's an arterial line above
Yes.
in the arm,
so that
right?
the-
Because
so that- yeah.
correct, because you need to see that there's absent flow.
radial would be.
Left, right doesn't matter.
Most of the
But
patients
yes.
usually have an ALI in C2 already. So there's no flow in the arterial. It says that once the circuit has started, there's no trace in the arterial. That means there's no flow which is coming into the thoracic. Okay. So we know the balloon is in the
So I'll take half a minute here.
indirect way of confirming this.
Yeah. So for people who are not familiar, we are going to start a circulation with femoral artery. We don't want the blood going up to the thorax. So we are inflating a balloon in the abdominal aorta from the suprarenal on the contralateral side so that there is no flow above. So the flow is in the liver, kidney and the pancreas, right? Yes. Now the question is about how much to inflate. So I was talking to the vascular surgeon. He says, don't do a fixed volume. So what happens is this takes the shape of the aorta. So as we are inflating, they do it under fluoro. So as they are inflating, it takes a sausage shape, the shape of the aorta from the round shape. And when they feel that it is a nice sausage, that is the size to stop. Don't do a fixed volume. That is the recommendation from the vascular surgeon. Now, how do we do that with X-rays? We'll have to work it out. We do about 25 ml and then see. So with practice, we'll get to know that. But the practical important thing is that the balloon should become the shape of the aorta. Then you know it is holding it nicely. And Dr. Kumud was talking about having a radial artery in place because you know that there is no flow in the upper part of the body is that the radial artery would become flat. So that is how you make out that there is no flow happening in the. Yes.
So one correction here.
Yeah.
So we said,
Dr. Ravi.
yeah.
keep
So
talking.
one correction here that we said that the balloon has to be in suprarenal. It should not be supra. It's in mid thoracic. Correct. Not suprarenal. Supra diaphragmatic. Mid
Supradiaphragmatic.
Sorry, yeah.
Yeah.
So now, once these cannulas are in C2, we are going to be attaching the blue venous one to this venous port.
Okay.
From here, the blood is drawn. Okay, it goes into the reservoir. Right. Now remember, this side is a passive flow. Okay, there's no pump which is or suction which is pulling it.
Connected?
Sorry, it's already connected.
No, what I mean is this side. Not possible.
Sorry?
Can you connect this side also?
So can I
Connect with the cannula.
We can do that. We'll have to open.
आप भी आओ ना बेटा साथ में.
With practical demo.
आगे से कट करो. इसे काटना पड़ेगा.
Scissors?
Because these are small things that
Yeah.
This is for any ECMO. This is correct.
No, I know, but still.
I know we're just showing this, but if you were doing it right, then of course you need the steps of clamps, both sides
Yeah.
with fluid in between, dripping the fluid in before you connect, so you don't entrain air.
No, connect.
Okay, so what we do, what he's actually saying is that when we have the blood coming out, there's some air here. And as soon as we connect it, there's fluid inside this tubing. So there's a small column of air here also. So we don't want to just push that. So somebody will be just pushing in saline from the top, and we just sort of attach both of them together.
So for an ECMO person, this would be a routine
It's, a-
thing.
it's for everyone. Yeah. And once we do that, they just remove the clamp and allow the flow to go inside. Okay, so now what happens to the flow? Let me just talk about the flow. So what is the modification in the ECMO machine that we have? So this comes here, goes to a reservoir.
Can you show the reservoir?
No, a reservoir is not a part of a standard ECMO circuit. This is a CPP reservoir. It's kept here. Now, in case I don't get a very great flow, for whatever reasons, there is a backup facility of attaching some negative suction also to pull it. This can give low volume suction also to pull it. Okay. This is a add-on kind of a thing which you can use. Some people use the wall-mounted one, but the pressures can be extremely high, so we do not like to do that. But this is only in the case where the flow has not come.
Very section attached to which part of the.
Yeah. It's already attached. It's a closed kind of this is a closed container. So it's just applying a low level of suction just to drop. It was not what I had said, but something which can add.
Okay.
Yes, so from the reservoir, you see this one going into the pump. Till here is all set. Now the pump which propels the blood forward. From the pump, it's coming into the oxygenator, which is attached.
Just show us, if you don't mind, the arterial one going into that pump.
Yeah.
No, this arterial tube which you have.
This one's arterial.
Yes. Just trace it down.
Okay.
Arterial.
Yeah.
Detach the comb.
Yeah, sure. Fine.
Yes, so from here it's going.
Just detach the comb.
Yeah.
From here,
No, just take the corner.
Just for us to know exactly.
So
Between the
it's
pump-
at right angles.
This is
The inflow
inflow, outflow.
pumps out at
Okay.
that right there.
See,
Right.
inflow, outflow. So outflow is going into the oxygenator, which has an attachment.
The patient's blood has flown. And how much blood you want to come into the reservoir before you pump?
2.2 liters. 4 liters is the volume of the pump. We don't need a 4 liter pump. We need around just 1.5 to 2 liters. That's about
The
it.
reservoir is primed already.
It's primed. It's already filled with.
So just tell them that, yeah.
Primed with Martin's amount, certain amount of 4 units of blood typically,
You
right?
can do that.
Now,
It's already primed.
if I can just.
So how much blood we need in the reservoir before we start?
Typically, it's about 4 units. Now, depending on whether hearts are being taken or not, you don't have such.
So right now we're doing just abdominal.
right? Yeah.
So how much
But
do you
even
recommend
so-
for abdominal?
I just want to point out that even in this situation, because we now have circulatory death established, you can still do abdominal NRP and not exclude heart and lungs being utilized. So I would just wanted to add the little complication. We're now explaining everything, that this venous return is key. When machine perfusion requires a donor blood for the prime, like the heart would, this is where you would put a Y connector so that the first 1.5 liters would go to that, the heparinized bag, and gets used for the device.
Right.
Then you just clamp that, and now you have this already a pre-primed circuit. When you're using the heart, donor blood hemoglobin must be 10 or over, which you've already put into the donor. And then the rest is primed here so that you don't entrain any air as you run the pump.
So minimum 4 units of blood you would need, plus Hartmann's. Yeah, so we are publishing all this for everyone to read. Okay.
That's for the heart when they are talking about failure.
Okay, when the heart is not to be used, only the liver and kidneys.
You don't need them.
You just carry on.
As has been described.
Yes.
Okay, so you
Okay.
can have some amount of fall in hemoglobin. You can have a dilution also. That's not a problem.
Correct.
Okay, so that's not a problem at all.
Okay.
It's 12. Come all the way till 6. Not a
That
problem.
is before the reservoir.
Yeah. So the reservoir is just to sort of get some kind of a flow going on. 1.5 to 2 liters. You just need to get that forward flow from there, so the pump can push it forward.
Is this a reservoir which is hydrology? I mean,
Yes.
We'll just pause for a second, ladies and gentlemen.
Yeah, good.
Welcome, sir. We have Noto here, so welcome, sir.
Thank you.
Yeah, thank you very much. So we just started the demonstration,
Sir.
and we have reached the stage where both on the right side, the femoral artery and vein have been cannulated. On the left also, and now we are talking about getting the blood from here into a reservoir, which is usually not a part of the ECMO machine.
Okay.
So why we call it a hybrid system is because we have attached a reservoir for the purpose of NRP.
Yes.
This reservoir is what he's telling us about.
Reservoir is sort of creating a pressure head, right, to push the blood through to the pump, and that takes it to the oxygenator. The pump onwards is a positive kind of a flow where it's sending the blood forward. So this pump also has an attached to the blender and a heating unit. So you're going to warm it. You're going to warm it to 37 degrees. So that's going to happen here at this level. And this blood is finally out of this, comes back through the arterial,
Okay.
into the circuit, into the system.
So this reservoir is a very important part of this because Ravi, a few attempts at doing a NRP were made and people didn't know that a reservoir is needed. So
You got air into the
work. So
No, the pressure head, push it forward
Is
not
also
existing.
required.
So that's also-
second thing is that, when you are doing a abdominal only and which is what we are describing now, you need lower flows compared to when you are doing a thoracoabdominal NRP, which will be next described.
So how much is the flow?
For about 1.7 to 3 liters.
To 2 liters
For
should do the job.
abdominal NRP alone. For the chest included, it will be around 3 to 5
We
liters.
keep the blender around say 50% and say around 2 liters or so.
So हमारे साथ जो internist हैं, he is from the CTVS team. तो इनका यहाँ पे होना will be very important because जब भी ECMO मशीन चलाते हैं, ये हेल्प करते हैं. तो इस प्रोग्राम में CTVS and राकेश, आपको इसके बारे में थोड़ा सा कुछ और कहना है?
Yeah, it's a very important role in the reservoir because Suresh told always some stuck to some drain in the reservoir. Yeah, so जो भी एयर आता है वो एयर को हम इसके अंदर एयर रहेगा और इसके बाद ब्लड केवल ही जा सकता है. इसको कट ऑफ करेंगे तो in ECMO the some air suck and direct into the goes to the patient. So this is the role of reservoir.
पूछनी थी आपसे, ECMO में रिजर्वायर नहीं होता ना, नॉर्मल ECMO में वहाँ कोई रिस्क नहीं है एयर का?
होता है.
बताइए उसके बारे में. ECMO में कैसे?
जब पेशेंट हाइपोवॉल्यूम होता है या फिर सम काइंड ऑफ ब्लीडिंग्स, सो उस समय हमें एयर आने का, एयर सक होने का खतरा बहुत ज्यादा होता है. और दूसरी चीज, अगर हमारे फ्लोस बहुत ज्यादा है और पेशेंट वॉल्यूम कम है तो उस समय भी हमें सक होने का खतरा होता है. लेकिन जो ऑक्सीनेटर आता है उसके अंदर एक सिस्टम होता है कि वो 40 ml एयर सक रख सकता है और उसके बाद में उसमें एक वैक्यूम पोर्ट होता है. वो वैक्यूम पोर्ट उस एयर को, केवल एयर को बाहर निकालता है, ना कि ब्लड को.
दूसरा एक जो सवाल मेरे मन में आ रहा है कि ECMO में हमें रिजर्वायर की जरूरत नहीं है क्योंकि हार्ट एक्ट कर रहा है एज अ रिजर्वायर. सो द इज हार्ट एक्टिंग लाइक अ रिजर्वायर इन ECMO or in what way?
So it is
in normal ECMO.
Body is a
Whole body is a reservoir.
reservoir.
Okay, so it is under gravity.
इसमें आपने हटा दिया.
Under gravity coming out and just going through the entire system. So there the heart is pumping, the circulation is ongoing. So there's no need for this kind of things to be done. Air is going to come up anyhow. Any fluid air collection, the air will come up. The fluid will be on the bottom. So the outlet is at the bottom. So only the fluid part comes out.
So we have collected and now we are pumping warmed and oxygenated blood
Blood back
into the.
Now, because we have a perfusionist, I think it's important to state how important this role is. It is absolutely crucial for a number of reasons. One, they are the people who are telling you every 5 minutes from knife to skin or whatever you started the NRP, the timing. The other really crucial thing is in regard to that reservoir, particularly when you're doing thoracoabdominal full body perfusion. Because the level of the reservoir of the fluid is critical based on what you're flowing in terms of liters per minute. And unless you have a flow sensor, you will get very little, few seconds only before that reservoir empties and is full of air. So critically watching that.
Yeah.
But ideally, you should also have a level sensor to be protective.
Yeah.
Because at 3 liters of flow, and the reservoir, let's say, has a liter in there, at that rate of flow, you have about 20 seconds of thinking and acting time.
Yeah.
The moment that reservoir goes to 200 mils, you have now about 4 seconds.
So, हमारे in the people who have joined consortium के हमारे NRP के national के कुछ और भी लोग होंगे. Is anybody else there? Juvanna, is Kalai there?
I can't see Kalai online, sir.
All right. So
I can
he's
ask
the
him
one
to join maybe.
who is also one of our perfusionists who has been helping. So, any comments from the audience?
Yes. The pump is
That's the part.
The size of reservoir.
Take the volume, the reservoir, and push the volume of food to the patient.
The size of the reservoir will vary, or the size of the reservoir will vary, obviously, with the size of the patient and so on.
Yes,
Because this is about 1.5 liters, you said.
correct.
We would normally fit that with the size of the patient, whether it's pediatric adult. But in our context, we should just stick to the same kind of reservoir, recommend the same one. No. That'd be different. But for adult setting, what I'm saying, recommend a singular type of a modular system, knowing that jurisdictionally people can choose what they have. Now, for example, right now there's a national crisis. We do not have enough oxygenators for ECMOs right now. So we have to do your jugad and do whatever we can.
So this is about 4.5 meters.
So we have Dr. Naresh here. He's our CTVS anesthesia person. Aapke kuch any comments? Yes.
One more thing is there's a difference between the centrifugal pump and roller pump. So this centrifugal pump are these are preload and afterload sensitive. So it's not like when there's a mechanical roller pump that will give at exactly, for example, if you have set it at 3 liters per minute, so it will pump it out. But the pressure sensitive. So once the flows doesn't go, it will stop. So there's a inbuilt also mechanism that this pump will not run without the volume.
So I have one question to ask.
Yes.
About this reservoir pump. So are these standard things that are available everywhere?
What's the cost?
Right? What is the cost? 35.
ये जो आपकी ओटी में जो आप यूज करते हैं,
हाँ, ओटी में हम हार्ट लंग मशीन यूज करते हैं, उसमें रिजर्वायर ऑक्सीनेटर द पार्ट ऑफ
Similar types.
same.
Sir Kalai has joined us. If you want to give a little background to what we are discussing, he can help with this discussion.
Can you repeat that?
Yes. So what Naresh just described about the difference between roller and this pump is that's why we go and our criteria is the pressure that we read, we adjust flows to. So we're not giving just a fixed flow guide as to what roughly we need, but it's the pressures we are maintaining and adjusting flow.
So the patient NRP has been started and the blood is flowing, and the maximum duration that we can do this is about, say, 2 to 4 hours. So what do we have to now do over the next few minutes? Can we describe that? How we go next step? Yeah. So would you like to just tell a little bit on that, Dr. Philip? How do we see that the liver is working well? How do we see the organs? What are the samples to be collected? Anything.
Somebody's describing when you would take this patient to OP.
Yeah.
That's when.
That we have to just tell us a few. Now this patient was in the field. This has been established, and this is a portable machine, so we can take him now to the OT. So now the next step, how do we monitor the
organs? If the organs are not utilized, all this effort is wasted. So you have to establish that the organs are functioning when you re-establish the normothermic regional circulation. The kidneys may produce some urine. I normally never see more than 10 to 40 cc's over a period of an hour or 2 hours. But the critical thing is the liver. And the number one consideration of the liver is whether it's clearing lactate. Usually, if you prime with blood, there will be a high initial lactate. I like to prime with blood if the hemoglobin is 10 grams or less. Because sometimes some surgeons who are accepting the liver will say that your hemoglobin dropped too low, and so they are not certain the oxygenation delivery was adequate or not. So in order to satisfy them, we like to keep the hemoglobin around 10. So you will prime with blood.
That we prime with blood, is it?
You don't have to prime with blood. Once you prime with blood, your initial lactate is going to be high. Not a problem, because your liver will clear it. And generally speaking, an hour, the lactate will drop to 50%. If your lactate is dropping to 50%, your liver is working. If you're doing laparotomy also, you can do a biopsy of the liver. So you have two parameters to decide whether this liver is going to work or not. And once you know that the liver is going to work and you place it with these two parameters, they always work.
And in BV, usually lactates are normal. Like if it is properly managed, the lactates are somewhere around 0.8, 1.2, 1.5 like that. So how much do you anticipate? Like you must have seen how much you said when you prime, then the lactates increase.
So let's repeat the.
The question is, when a patient is brain dead, they're being managed in the ICU by very expert people, and the liver is clearing lactate. So when the patient comes to the OR, the lactate is normal, below 3, maybe even as low as 0.8. When you go to DCD, the level of lactate rise depends on the agonal time, or what is called the functional warm ischemia time. Now, the problem is many centers will say they will not accept a liver if the functional warm ischemia time is more than, let's say, 30 minutes. Okay. Now, this is a problem because I'm twice your age. If we both go to withdrawal of life support, whose heart will beat longer? Your heart will beat longer. So, with you, the functional warm ischemia time will be more than it will be with me. But your organ is likely to work better than mine. So, this is a paradox. Bottom line is, the longer the functional warm ischemia, the higher is going to be your lactate. But the clearance of lactate will be better with you than with me, and that will be the deciding factor. The initial lactate, I have seen between 6 to 14. And when it clears, within an hour, you'll be 50% of that.
So do we have in the audience, is Darius there or Chris there? Anybody from UK or anybody from Spain? Okay, so they haven't yet joined. So what about the role of AST and ALT? Can you specify that?
The only reason to do an AST ALT is in the recipient. It becomes your baseline, to which you compare how the recipient liver, how the liver is working in the recipient. So if your AST ALT were 1,000 and in the recipient is 2,000, that means your right is 1,000. So it helps you to better function in the recipient, but it is not a criterion for acceptance of the liver.
I'll ask you a question. And again, you said 4 units of right? Initially.
Sir, we keep 8 units in the OR. When we go to the WLST or we go to a DCD program, we ask for 8 units, PRBCs. Now that you may not need to use at all, but you have to have that available.
This is why you said.
Sir, when you prime it, you have to decide whether to prime with crystalloid, colloid, blood. Generally speaking, every center or every perfusionist will have his preference of the prime. You can ask them to include blood if your starting hemoglobin in the recipient's ICU labs is low.
Maintain around. And आपको prime करने में
certain hemoglobin. Only for the heart, people expect it to be more than 10.
All right.
if the hemoglobin is 5, are we okay?
No. Above 7, 6 or 7.
So we have to specify a hemoglobin. So 10.
Actually thought of a hematocrit of 20 to 22.
We have written in our guidelines that
Yes,
hematocrit.
as an hematocrit, yes.
So at hematocrit.
Yes, sir.
Yeah, which is about 6, 7.
It does matter.
I didn't get the question.
Lactate. Blood.
So
fresh
when you
bone.
give blood, the lactate is going to go up because of the blood. The problem is, if you have to give blood during that 2 hours you're running the circuit.
So now can we switch to a thoracoabdominal approach because we don't have too much time and
We can do also
Take for blood, read into the reservoir, and to pump it back into to start the perfusion. And what about the perfusion of organs during that?
So it's minute, second.
It has to be.
what should we
We'll do it here.
You do here, not here.
Or some centers use up to 30.
and showing you the
Heart-lung machine.
heart-lung
But
machine that is used.
Just
This catheter
yes,
will go through right atrium.
right atrial appendage, and it goes in. You direct it into the IVC. It is designed in such a manner that some of the holes will remain in the right atrium, therefore draining upper body blood, venous blood, and the tip will go into the IVC, draining lower body blood. Now, just to move on, so now just like to describe when you're doing abdominal NRP, what happens in the chest, right? So yeah, so this is a two-stage cannula. You can see which has it's much bigger, and it has this hole over the blue area, which is going to sit inside the right atrium, and this tip part here beyond the wire reinforced element that sits into the IVC. Right.
So this will stay here, and this is the aortic cannula.
This is the aortic cannula. It's like typically a 24 French cannula, which will sit there, right? Ascending aorta. Because if you're using the heart, B, you must have enough donor aorta to do your recipient anastomosis. So high up into the ascending aorta or even proximal arch.
All the three brachiocephalic arteries will be
Clamp. And it's critical that that clamp does not then end up clamping partially or fully the descending aorta, because you just turned it into a disaster by doing that.
Yes. Also, you would like to clamp the aorta low down so that there's no flow in the limbs?
No. So that is before we retrieve organs. Now, if we just go back one step to the peripheral scenario of abdominal NRP, where we are taking heart and lungs, then you would do the median stenotomy. There's several really critical steps. One is that if you're taking the lungs, this patient would have been re-intubated, right, already. The first thing you do, almost from the bed coming in, is to re-intubate before you put it, because you can otherwise get contamination from gastric contaminants into the lungs, and that's a disaster, particularly when the guys in the abdomen start manipulating. So if we're now taking the heart and lungs, then again, the clamp is critical, but more importantly is a vent in the aorta. So that ascending aorta, the same pipe that we put in here, is put there and left open, because there should be no retrograde flow beyond that balloon. Now, if the balloon is not being utilized and we're doing this together, we would put a clamp on the descending aorta above the diaphragm, which again means once you've done that, or the endoluminal balloon is effective, then no blood, or at least nothing oxygenated, is going to come up this tube. If there's flow coming up here, we have to stop. Or if the heart starts to beat, in the absence of us giving perfusion antegrade, then we have to stop, because there's an issue, right?
Yeah.
And then you can proceed.
Yep.
And for the heart and the lungs, you need to put a vent in the pulmonary artery. Again, the same cannula that we use to give the pneumoplegia in.
So now
we'll left open to vent, so there's no acute pulmonary hypertension.
So we have only 10 minutes for the OT.
Yeah, sorry.
So we'll talk while we are going, but one last comment.
Is that when you've, for the lungs, when you've reintubated and all this other thing is going on, one of your team members can do the bronchoscope, do bronchial toileting and so on. And that can be repeated when all these abdominal assessments are going on. Yeah.
Okay. Let's go to the OT now with the camera. We'll see you soon, everybody. Hello. So we're back in the OT now. Hello.
Most efficiency.
Yeah, very important. Audio on करा दे.
Audio on करा दो. आपकी audio on है sir?
Are we on? Can we hear? Can anyone hear us? Okay. So we are in the OT now. Quiet, please, everybody. Excuse me. If you can stop talking and come here, everybody. So इस मशीन के बारे में बताइए जो हम लोग एनआरपी में यूज कर सकते हैं ओटी में जब एनआरपी होता है.
सो ये हार्ट लंग मशीन है, हार्ट और लंग्स की तरह काम करती है. सो सब कुछ स्टैंडर्ड है, बट ये होता है एक वीनस ड्रेनेज. ये पेशेंट से हम वीनस ब्लड लेंगे और वीनस ब्लड लेंगे. इसके बाद में ये वीनस ब्लड रिजर्वायर में कलेक्ट होगा. देन द पंप रन होगा like this, एंटी क्लॉक। यहाँ से पेशेंट पंप में आएगा, ब्लड पंप के अंदर आएगा, देन पुश इनटू द ऑक्सीनेटर, ऑक्सीनेटर के अंदर ऑक्सीजन मिक्स होगा, ओके। ऑक्सीजन मिक्स होने के बाद में सेम थिंग्स वापस ब्लड पेशेंट के पास।
तो अभी हमने जो आईसीयू में देखा दैट वाज एक्मो बेस्ड विद अ रेजर्वॉयर, और ये हमारा जो मशीन है ओटी में, सो व्हाट इज द कॉस्ट डिफरेंस व्हेन वी यूज एन एक्मो मशीन रेजर्वॉयर के साथ और जो आपकी हार्ट लंग मशीन है? अगर हमें 2 घंटे 4 घंटे के लिए एनआरपी चलाना है तो कितने पैसे में फर्क पड़ जाएगा?
अगर आप इक्मो के साथ लेना चाहते हैं तो 25 to 30,000 सेंट्रीफ्यूगल पंप जो हम यूज कर रहे हैं वो कास्ट कट ऑफ हो जाएगा अगर हम हार्ट लंग मशीन पर लेते हैं डायरेक्ट पेशेंट को।
तो ये सस्ता होगा?
ये सस्ता होगा।
तो इसका कॉस्ट हमने जो जुमन्ना आर यू देयर? हेलो, मेरे को सुन सकते हैं?
Yes, sir, I'm there. I'm online.
You had worked out for our paper that the cost of using a heart lung machine in the OT would be around 50,000 rupees.
Yes, so it is 50,000 cheaper than the ECMO cost, because in the ECMO machine, like he said, we need to use an extra pump, which is the pump head, which is not required in a heart lung machine. We are using this cone. We are using the same. We are using the same oxygenator and reservoir for both, so that is a same cost. The cannulae are again different. The cannula we are using in direct cannulation of the vessels post laparotomy or post sternotomy are combined they come up to not more than 20,000, while the ones which we use for ECMO would be around 50 to 60,000.
तो एक्मो के जो कैनुले हैं वो 50,000 रुपीज
ईच कैनुला।
हाँ,
50,000 ईच कैनुला।
तो कैनुला का कॉस्ट इज मोर and we have the cone which is more,
and also
we have the balloon that we need
which
we don't need in the OT.
Yes.
So from about 50,000 it increases to about 1,20,000.
Yes, sir.
Almost double, right?
Yes, sir, correct.
So 50,000 is quite affordable because it will be shared by the recipient. So Dr. Kumar?
There's another cost we haven't factored in, and you'll notice the difference between the ECMO circuit we saw and this heart lung machine is that here you can see several pumps rolling. These are roller pumps, okay? While the ECMO, you only had one cone that was working, which means what do you do with the bleeding? So when you're dissecting the chest, abdomen, there may be bleeding. So in the ECMO, the only way you can get that back is you have a separate cell saver from which you can salvage and do it that way, and therefore incur the cost of disposal of the cell saver. Or you need to have one of these modular roller pumps to be able to attach to that ECMO circuit, so you can use that as a sucker that then blood goes into the reservoir. While this already comes with multiple roller pumps, so that the blood that is lost can be salvaged and put back into this reservoir.
Thank you. So, question. So the question is, is ECMO with a reservoir, the hybrid system, better? And when we mean better cost, we've already said. Now you want to know what is better in what way?
So quality of organs will be same because we are just giving the exact same circulation. But the main two things is, one is cost and two is portability. So this is more portable, cheaper, but requires the whole process to be done in the OR. That one is more portable and requires cell saver also, so that additional cost may be around more.
So the heart lung machine is not portable. Heart lung machine can be used only in the OT. Yeah.
So if by chance we should directly try to shift the patient to OT and
so now, Dr. Philip, the question asked is, if we have a chance, should we do this whole process of withdrawal support in the OT, or we start in the ICU and then shift to OT? Because if we shift to OT, what are the advantages besides the cost?
Shifting to the OT is the only thing I've done. I would not want to go to a hospital, especially many of these DCDs are in small hospitals, where sometimes I've not even had a sternal saw to open the chest, open the sternum. So starting all this outside the operating room is extremely hazardous. And anything goes wrong, people in the US are so risk averse, they will not accept the organs. So the most stable situation is bring the patient to the OR, DCD3 type, set up everything, let the family members be sitting with the patient. When the when the arterial waveform flatlines, they are escorted out. 5 minutes later, death is declared, and we start the NRP.
So, what Dr. Philip has said is about DCD3, where we are withdrawing support and that room close by. Since we have not done withdrawal of support much in our country, Dr. Shroff, Dr. Mathur, all the seniors here, Dr. Noto is here, we feel that DCD4 would happen maybe tomorrow, where a brain dead person is unstable. And Dr. Shrikant, where are you? Dr. Shrikant in the ICU here, he's going to do it in the ICU, the part that we've shown you in the ICU there. And only once we are ready for the organ retrieval, we are shifting that patient on ECMO. We have used it in the elevator also, that ECMO machine. We have been taking people for CT scan on ECMO. So that is extremely portable. And we can move to the OT and then do the rest. So both scenarios we have to be ready for. But withdrawal of support, when we do DCD type 3, then most definitely OT would be the preferred. But we have to be ready for both.
I want to ask this ECMO, no, you said that the pump is an extra cost. So is it a disposable pump or that's why it's an extra cost?
Yes.
It's not one time. Okay.
It's about 30,000 rupees.
Yeah.
And the word they use is cone.
Yeah.
We have to get used to all these terms.
Cost of cone, tubings, and potentially cell saver. These are three added costs. So it will go to 1.5 to 2.
So balloon, of course, we are using only in the ICU. Once you're in the OT, you can open and clamp your aorta. So
No.
Yes. Every time. You have to be ready for it. If you start bleeding, that blood cannot go into the trash suction. You have to save the blood.
also, what you have to be ready for is a super rapid recovery. If you are unable to establish your flow as we are starting, then at least go for the super rapid recovery and do what we can.
That's why I like what Kumud says, that, do the thoracic approach. So your sternotomy is already done, your organs are already seen. What do you say?
You can only do it in type 3. You can't
Yeah,
do it in
yeah.
type
Yeah.
And I think that balloon thing is difficult to do in ICU
Yes.
Ready for that?
without a fluoroscopy.
1 second, sir. Okay, now we are running short of time. We can have discussion. I'm going to show you how Dr. Beena, every system, kaun dikhayenge? Haan. So every system now, this is very important, Ravi. Huh? Can you hear me now, everyone? So we are saying that we need a record of what happened when we withdraw support. How when we have a flat line that it was there for 5 minutes. So we need some kind of proof that whatever was there has been adhered to. So every machine, a monitor has trends. So we have set this trend so that every 5 minutes, everything is recorded. You can make it 3 minutes, you can make it 1 minute. But as what we would recommend, Ravi, what we would recommend all of us to the country when we start this is that we set the trend as 5 minutes. Is it okay? 5 minutes? And then आप एक बार दिखा सकते हैं कि कैसे होता है ये?
हर 5 मिनट में इसका शो करेगा कि इसका हार्ट रेट, पल्स ऑक्सीजन, SpO2, हार्ट रेट और आर्टेरियल टेम्परेचर जो भी
So
every 5 minutes का देता.
now the important thing is कि once we do the next patient, all this is erased. So एक बार ये सब हो गया, so somebody has to take a camera and take pictures of the relevant time periods, which we should also specify in our manuscript. These are the minimum pictures that we should take and record.
Some of these come with printers.
Yeah, correct. But
Okay.
some also have a
So
memory.
it has a memory. So some of them come with memory store and printers. So if there's a printer attached, you can take a printout too. In case, in many places in our country, we don't have printers with every monitor. So in that case, of course, you can take a picture.
We are doing pictures in US, Philip. In US, we are taking pictures. No.
There will be several teams. there'll be several teams waiting in the lounge of the doctor's lounge area or in an adjacent operating room, and everybody wants the trends. So the coordinator takes the pictures and sends it in an SMS message to all the surgeons, cardiac, lung, liver.
So the important point is that the surgeons are not allowed in the room till there is a 5-minute flat line. So that also is very important.
So just to point out, I think one of the big differences between Philip's practice and mine, or more European style or Australian practice, is that in the US, you're more likely to have the withdrawal taking place in the same theater as the retrieval. Am I correct? Right? So elsewhere, the withdrawal is happening in an adjacent theater because the retrieval surgical teams are next door, already prepped, prepped and gloved and ready with all their trolleys to receive the patient from the next door once that certification of death has happened. Now, the other place that can potentially happen is obviously ICU, then the patient is rushed in, from which they're rushed in, because different jurisdictions will have a different acceptance of where it is culturally or from an information point of view, understanding where the family can go.
Or not mean to say the family can be in theater?
Absolutely. Yes.
I mean,
that's what.
Sense. So you want to be in sterile area where you want.
We'll talk about all this because we have just half an hour now before. So let's take one nice picture here. With permission to bring down the mask for picture. Thank you.
Sorry, just one last thing, which is that what Philip was mentioning, and you asked him about this communication.
Yes.
That is critical. So the communication between this place where the withdrawal is taking place to where the OT of retrieval is, there has to be timely, that's 5 minute, whatever, or milestone directed communication so they know exactly what's happening with the trends.
Thank you. So we'll take a break now and join after lunch at 2 o'clock sharp. Let's take a picture, guys. Isko off kar de. Where do we want to picture?
Sobre todo, sí, sí, sí. Bueno, ya empiezan. Vámonos. Vale, chao.
Can you hear us?
Hello, morning, morning.
Mati, can you hear us?
Yes, perfectly. Very happy to see you. Wow, Kumut. Many friends here.
Yeah. Hello, hi, Brian. Darius.
Hello. Sunil, also Sunil. Oh, Darius.
Hi, Marty.
Very nice. So we have been, in the operation theater and in the ICU. We learned how to do things actually on ground because we haven't done NRP in India as of now. So we look forward to the session and all your inputs. Good. No volume. How's the volume?
You may have right to that.
Darius, the volume is poor.
Have right.
How's the volume now? Is it better? Should I hold it in my hand? Can hold it. How is it now? Better?
Improving, yes.
Okay, much better. So whoever speaks, I think, can hold this in their hand. That may be better. Yeah. Anything else? You can see us well. Yeah. So where do you want me to stand when I start?
Here only, speaker.
Will that be better?
It's better you can stand there.
So whoever can stand. Right. So good afternoon, everyone. It is my privilege and pleasure to welcome you all on behalf of Manipal Hospitals and the organizing committee. So India does about 20,000 organ transplants in a year, and we are third in the world after US and China. And now with brain death being declared more and more, we have almost 100 organ donors every month. And this has been possible because of almost 22 decades of efforts by stalwarts, some of whom are sitting here, Dr. Anil Kumar, Director Noto, very warm welcome to you, sir. Can you focus the camera somehow, or you can wave, sir? Dr. Anil Kumar, Director of our national program, thank you for being here. Dr. Mathur, Dr. Shroff, please wave your hand. Dr. Mathur is this side, yeah. But now we need to move towards DCD, and about 30 of us have been working for a few years on this. We published two guidelines, one in 22 and one in 24. And we have done 68 DCD kidney transplants in the country so far. But to increase the utilization of all organs, we thought that NRP was the way forward. So we have a national consortium of experts, and we have been working on this, and we are almost ready with the document. So a part of our consortium is our expert, Philip. Thank you, Philip, for being here. I don't know how many of you have met him earlier. Philip is based in Texas. Philip and I are from the same college, Armed Forces Medical College and PGI Chandigarh. And we have met as a consortium of 11 times so far. And he would wake up at 5 o'clock and never miss the meeting. And it is amazing to see how at 5 in the morning, he is so articulate and his clarity of thought. And thank you for coming all the way, Philip, to be with us today.
It used to be 4:30.
All right. Yes. Thanks also to Kumud, who has come all the way from Chennai, Ravi, again all the way from Mumbai to be with us today, and all the consortium members. So we'll start the ball rolling soon. My hospital director is busy with something, but we are all here to take it forward. We can request Dr. Anil, our director Noto, to please join us in lighting a lamp, which we normally do, and all dignitaries to join. Please come. How will they see the lamp now? Will you turn your... Come, sir, Dr. Anil Sarai. And we'll request everyone to come for a group picture of right. Dr. everyone. Meet the seniors like the CD is going to pick up with it. Welcome. You have a good picture. One more like one. All of it, yes. Thank you.
That's why he gets the last say.
highly successful. So back to now, everyone in. Philip, please come to the middle. Take both of you come to the side. Oh, we're back. Come. Up here, na? Come on. Come, Supinder. Most part was, yeah. After now, Supinder does all our coordination for last 15 years. All are in? Thank you. All right. Thank you, everybody. Dr. Lee, you were- Just thank you. So thank you for your patience. And when we present our national protocol, we have experts. Yeah, we have experts from Spain and UK joining us. A very warm welcome again to all of you. And let's hear from Director Noto a few words on what you feel about this.
Thank you, Dr. Seth. Good afternoon to all. Really great initiative by all the stalwart there. We have experts online available, and definitely we look forward to a new, basically way of generating our because now we have in our society the awareness is increasing. People are coming forward for donation, and many times because of the many situations like that, or because of the patient not going into the brainstem death stage, these situations we are not able to help them with donation. Families are now demanding donation, so that is also one demand for donation from the family side, their rights, because they are realizing that it is their right to be asked for donation. So, and the as a government has to provide a system to help them with donation. So what we see this initiative as a way to have an alternative in for various situations where we can have option that to utilize the donated organs. So definitely this DCD with NRP uh, perfusion that we are trying to understand and trying to implement in the country, and all our experts which are involved, and they have been working so hard for this to be implemented in a very ethical and legal way in the hospitals. And the entire group is working for, I think, quite some time, more than about a year, more than a year. Yeah, about 2 years, and we have drafted good guidelines also, and we hope that these guidelines will pave the way for increasing donations in the country and help those who are waiting for these vital organs. And definitely the aim remains that when we are implementing any such guidelines, the organ should be able to be utilized, and organs we should be able to get good organs. So that is the real aim when we are like implementing these guidelines, that the hospital should follow a protocol where they are able to salvage the maximum organs, good quality organs, which can be accepted by the recipients and their hospitals. So that is the aim, and all these meetings, the discussions which have been going on for a long time, they are aiming towards that, and we hope to have because legally in our country, donation after cardiac death is allowed or circulatory death is allowed, and we don't see any problem in implementation of the protocols that have been worked out, and only with the support and practical aspects that our hospitals and experts are trying, like now, have really understood well. We hope to take it forward, like implementing one by one, step by step, like to, as you know, we really don't want anything to be done which is perceived as unethical, or which is perceived by the families, because we have a very sensitive society, and we don't want that kind of any kind of a, that whether to have any legal roadblock or any ethical roadblock, because we are moving very cautiously and definitely, and but we want donors, but donor numbers need to improve. We have a lot of requirements, huge requirements, and this is a donation after circulatory that we see as a big opportunity for the country to increase the pool of donations, and that we definitely looking forward to. And thanks to all the experts who have joined and taken forward this initiative. Thank you.
Thank you, Dr. Anil. Miss Viji has joined. She is the hospital director for us, and all this is not possible without the complete support of the organization. And we have 37 Manipal hospitals, and we are trying to establish best practices in organ donation in all of them. And I'll request Miss Viji to say a few words.
Good afternoon, all. It's really a privilege and it's an honor for Manipal Hospital Dwarka to host this consortium. And because we believe in organ transplant as a noble cause, and chaired by, with our chairperson, we have a specific program which is managed by Dr. Avnish Seth, that is called MOST, where the entire Manipal group is working towards creating awareness and also promoting organ donation program. And like sir, you have just mentioned about this new approach, or maybe this is something which is already there, but it is important that more and more awareness is brought into this. And I'm sure this consortium will bring in that. It provides a platform to enable discussions on how to implement donation after circulatory death. And this initiative and this dialogues which are going to be presented today will initiate, it will be a catalyst to expand more and more the donor base and expand the donations, organ donations, which is the need of the country. And it is also considered to be the greatest gift. It is a gift of life. And we are very happy to be partnering this. And I'm sure this will be a beginning to bring in a change in the way the country looks at organ donation, and to open up more opportunities also. And thank you so much for being here today. And I'm sure this is a great initiative, and wish all the very best. And, thank you so much.
I'll request you to just honor our chief guest with a little token. Come, sir. No, come on. Just a little memento.
Thank you for being here. Makes a lot of
sense. Thanks to the Manipal group for hosting this, and most basically taking this forward.
One picture. Thank you, Vijay. I'll now request the chairperson for our first session, Dr. Mathur, to please take your seat. So we'll come this side. They can see us better. And Marty is our second chairperson. Marty needs no introduction. He's been to India to us, I remember, at least 7-8 times, and as the president of DTI and the Transplant Institute Foundation at Barcelona. He has been most helpful every time. Thank you, Marty, for being here. Would you like to say a couple of words before Dr. Mathur introduces our speaker?
No, my pleasure to be here with you online. We have been here several times, and the work that you do is excellent. And I congratulate you for this initiative. And I think from today, we can have a good recommendations to improve in India the practice of the DCD donation. Thank you. And I'm happy to be together also with Kumut and with Darius. I've been shared with you many evenings and many meetings, and it's a pleasure.
Thank you, Matthew. Yeah. So, good afternoon, everybody. At the outset, I'm thankful to Dr. Avnish and the Manipal Group of Hospitals for inviting me for this meeting here. And it gives me great pleasure to introduce my friend Philip Thomas. I know him since 1995 when he returned to India, to Bangalore, after receiving his training in the liver transplantation and multi-organ transplant from the Makkah of the liver transplant, that is Pittsburgh, under Professor Thomas's charge. And that time, while we were struggling to set up the process in Maharashtra, he was the one who was setting up the processes in Bangalore and was responsible for creation of the organization called Forte, and was also responsible for doing few liver transplant at that time, I remember correctly. And yes, he had been in and out of the country because his passion was he wanted to establish something, and when he found difficulty, he went back to the US for further spending some time, I think, contemplating what he should do, and he came back again to India, and this time in Kerala, he set up the liver transplantation program. Now, currently, he is again in the US. He is with the University of Texas as a medical director, and his current focus is on DC donation using the technology of Nrp. And that's what is forte today. And I request Philip to start.
Thank you, Dr. Mathur, for the kind introduction. Dr. Anil Kumar, pleasure to meet you. An honor that you are here. Dr. Avnish, thank you for all the work you're doing and heading up this important initiative. Thank you also for the invitation to be here. About 2023, I had a decision to take about whether to try and continue to be a primary surgeon in a transplant unit or to use seniority and skills to be a facilitator for other people younger than me and very good surgeons who needed to go the next step in this business of transplant. So I moved to San Antonio to just do a few days per month of organ retrievals. And having studied the problem, studied the concept of normothermic regional perfusion, I thought I would start focusing on that. And from October of 2023 to about February of 2024, all that I did was talk to ethics people, talk to units that were doing transplant. People were not happy with this idea. They were suspicious. They didn't know whether it would work. There was a whole new industry of normothermic machine perfusion, which is ex vivo, which for some reason has turned its face against NRP. So, dealing with industry can be daunting. But whatever it is, we made a start in February last year. And the program was so successful that by October, they wanted me to become the medical director of the program. And so that's what I do now. But my main issue and focus is on normothermic regional perfusion. So this is good. So my objectives are to discuss this new era of donation after circulatory death. We may call it cardiac death, but in reality, if there's pulseless electrical activity, it is still death. So we only go by the arterial line to see when the arterial line flatlines, because that is the end of circulation, circulatory death. To get a good art line is critical to making this diagnosis. I would like to only discuss a few practical steps. Dr. Ravi and Dr. Avnish have all put together an extremely comprehensive document, and there will be everything that you ever wanted to know about DCD and NRP in that document. My focus today is just on being practical in just discussing what is practical. The most important things I feel are two. One is you have to have an intensivist in the ICU who will be a champion intensivist and promote DCD with planned withdrawal of life support, that is WLST. The next thing I would like to discuss is a few details about the surgery and basically how to organize expert surgical talent. Because most consensus of opinion has been that this surgery should be done by people who are a little bit more senior, a little bit more able to absorb any negative fallout from mistakes or suboptimal organ function following DCDNR. I'm not trying to say that only senior surgeons can be the experts, but once we have experts, we should identify them, bring them together, share their expertise, and regularly debrief the cases that are being done. So just to put in context what is going on in the US, I think it's okay to discuss what's going on in the US because what happens there and what happens here in India are similar in a lot of ways because it's a democracy, it's very much multicultural, and a lot of the trends are about the same. So it's in 2020, since 2020, and I don't know why, I don't think anybody knows why, there has been an increase in almost 23.3% in the number of donors. Now, the important thing is that this increase in donors was mainly driven by donation after circulatory death. The number of brain death patients has remained constant around 10 to 15,000 per year. When you look at this graph, these are graphs which have come out of OPTN. They are national data which has been compiled. These are the number of donations. There's almost 25,000 donors per year in 2025. The problem is that there is almost 12,000 organs discarded every year. This is the figure from 2024. And the number one reason that they are discarded is because people have been forced to do super rapid recovery after declaration of circulatory death. When you do super rapid recovery, the kidneys usually can withstand the period of anoxia or hypoxia, but the liver suffers. And as you know, no liver surgeon will be willing to put his patient at risk with an organ that may not function. So the solution for this is, this is just a collage of the number of publications that came out about this organ wastage. Because everything we do in transplant attracts public attention and scrutiny, and there was a lot of negative fallout from this fact in the US. This is in my own OPO, of which I'm now the medical director. As you can see, the number of DCD donors has jumped up to 40% in 2023, and there was a small decline in 2024, and that is again on the uptick. So 30 to 40% of all donors are going to be donation after cardiac death. Now, we've had a little discussion about DCD versus DBD. The lower square on that slide shows the number of patients who were primed for DCD donation, but they progressed to brain death. And the whole donation could happen in the usual way as in brain death donors. In 2021, there were 50, and in 2024, there were 41 in my OPO. So that is possible. These are the organs transplanted. The gray line is kidneys. And as you can see from DCD, there have always been a majority utilization of the livers, 130 livers in 2023 and 119 in 2024. The red line, the red bars are of liver recoveries. And as you can see, these have been going up. Not all of these are because of NRP. Many of them are because of machine perfusion. And ex vivo, so you recover the liver super rapid and you put it on a machine which will perfuse it on and until the time of transplantation. So what are the lessons for us from the US experience? Number one, DCD is the main growth area in transplant as of now. Organ wastage is a problem. And I would submit that NRP is the best solution for solving this organ wastage because you can prove organ function before you explant it from the donor. This is the number one thing. The legal hurdles are several and continue to be a challenge to uniform application of NRP. And till now, there is no consensus on who should actually do the NRP procedure. Should it be a transplant surgeon who has provisionally accepted the liver? Should it be the cardiac surgeons who have provisionally accepted the heart? Or should it be trauma surgeons because trauma surgeons usually run the surgical ICU? Should it be the organ procurement organization where you can consolidate a lot of experience if the OPO surgeon goes out and does the NRP, and if another surgeon wants to come and recover the liver and the kidneys, so be it. So there is no need for us to repeat these kind of fumbling and hesitation approaches in India. Some definitions and clarifications. This is the jargon of DCD, WLST, withdrawal of life support. It is important to know that this is done by the treating doctors, usually the intensivists, and they are allowed to give sedation and comfort measures. The most common ones being used in the US presently are morphine, fentanyl, and one benzodiazepine, either Ativan or Versed, at the time you take the endotracheal tube out. The location can be OR versus ICU, and I believe uncontrolled DCD is best transition to super rapid recovery and not try to do NRP, which requires that you go an hour before, set up the OR so that you get a successful outcome. The duration that you are permitted to do withdrawal of life support before you transition to comfort measures only is determined by each hospital. Usually it's about 120 minutes. After 120 minutes, if the patient has not died, you have to take the patient out of the OR and keep them in an area of the hospital where they do comfort measures only. The other question which arises is what is warm ischemia or functional warm ischemia? Should it be systolic blood pressure 80 or should it be 50? We all know that at systolic blood pressure of 80, some circulation is maintained. Mean arterial pressure is definitely very often over 60. And so perfusion of the organs keeps going on. And you don't know, this can last 1 hour, 1.5 hours, up to 2 hours. But usually when systolic blood pressure drops to 50, death is imminent, flatlining is imminent, and within 10 to 30 minutes, death is going to happen. Pulse ox used to be a criterion for monitoring warm ischemia. It is now consensus that this is useless. So now, what is the time that the organs are ischemic? This is the agonal phase, whatever you describe it, from the time BP is 80 or 50, plus the no-touch time, which is 5 minutes, as we have already alluded to. Then the time taken from incision to start of NRP. Only this time is within our control. And there is a consensus that this time should be less than 10 minutes. Most of the time, you can do it in less than 6 minutes. And if you start going over 10 minutes, then people say that we don't want to accept these organs. So that is why the surgeons who do it should do it on a regular basis, frequently, to get this aspect of the surgery correct. And in the hurry to do things, don't, because we all know when you're in a hurry, you can make mistakes. So once there is a DCD, you have two decisions to make. Basically, is it going to be a super rapid recovery? Is it going to be a normothermic regional perfusion? We've already touched on this. Should it be, cannulation in the chest? Should be cannulation in the abdomen? And you also have to figure out the warm ischemia acceptable to each organ or center. So one center may want the heart, the patient is highest on the list, but they'll say if the functional warm ischemia time is more than 30 minutes, we are not accepting the heart. Another center may say we will take it at 45 minutes or 30 minutes. So you have to figure this out before you do the NRP, and you have to plan the site of cannulation with all the surgeons who want to be there and who want to be involved. Most of these organs which are procured by super rapid are put on a pump, either hypothermic, ex-vivo, or normothermic. What are the criteria to help predict circulatory arrest? This is a purely intensivist experience. This is his art. This is his science. I am not in a position to really advise on this, but usually these are the criteria which are looked at. What is the age of the patient? How many pressors is he on? What is the BMI? After that, it's all to do with the airway. Is there a gag reflex? Is there a cough? There's a patient on tracheostomy or endotracheal tube.
What is the peak inspiratory pressure with the cuff deflated? Are there any spontaneous breaths? Once you have absence of spontaneous respiration, absence of cough, generally speaking, in an older individual with a higher BMI, you're going to get WLST to cardiac arrest time, which is acceptable to most of the recipient surgeons, or within 30 minutes. This is what we use as a tool. It's a point scoring system. For each of those things that I mentioned, you can give 10 to 30 points. If the patient scores more than 180 points, is more likely to arrest. This is a way of auditing the tool. As you can see in my center, it's only got a predictive accuracy of 71%. Now, this is a picture of what we're doing. The one with the back to the camera is me. The one on the other side is a doctor. He's a Sikh gentleman from Northeast. And he came and he was doing a TA Nrp, and I was helping him. And I was there to just procure the abdominal organs. So till the end of last year, we had done 27 facilitated, what the OPO facilitated as runs. And all of the performance of transplant centers and OPO is monitored in the US. And so we had, by the end of last year, 26 transplants beyond what was expected from the yield of DCD. And so this became a big news and became a big factor in how we go forward with the NRP program and push it forward. This is the beginning part of this year. We've done another 6 cases, and we've had 16 organs transplanted, whereas only 9 organs were expected to be transplanted from those donors. What are the principles? I think we've gone over this in extensive detail during the preliminaries to this, so I won't get into this at all. We've got perfusionists who've explained this whole concept of reservoir very well. What we tend to do is, before we go out to the hospital where this donor is located, we have a pre-flight huddle with all the surgeons who are likely to be there. It is conducted on Zoom. We discuss with the liver team the acceptance criteria, heart and lungs, and who is the surgeon going to perform the NRP, and will it be the same surgeon explanting the organs. In the OR, it is important for an NRP that the surgeons and the NRP perfusionist team arrive at least 1 hour before bringing the patient into the OR. It takes about an hour to set everything up and to alleviate the concerns of the hospital scrub tech and all of them. You have to arrange one Mayo stand. I'll come to that. And you have to position, where will the perfusionist be located? If you're doing TA and RP, they have to set up all their equipment and their systems at the head end of the table, nearer the left shoulder. If it is abdominal only, you have to set it all up at the foot end of the table. You can't change this once it's all set and the patient comes in. You have to make sure the oxygen source, and I was very happy to see that the perfusion equipment demonstrated in Manipal has an independent cylinder for oxygen. Otherwise, you have to connect with the oxygen source which the anesthetists use. You have to make sure all those connections are okay. You have to have 2 sets of suctions. One suction or two of those suction ports will go into the NRP circuit. They are effectively a cell saver. There will be other suctions which are just trash suctions. They cannot be mixed. We have to discuss who will pronounce death and the process. Leave the OR after prepping and draping. Sit in the doctor's lounge or in an adjacent OR. Let the family come in and sit with the patient. They sit behind the drape, where, normally where the anesthetist sits. They keep a hand on the patient's pulse. They watch him. The anesthetist withdraws support, and then they sit with the patient until the cardiac circulatory arrest occurs, at which time they leave. Now, it is important that you go fast. So you cannot have, 30,000 instruments on the table, which normally be there in the OR, and then ask for, I want that. So this is how I set up the Mayo stand, which I will use. Now, you can see that you can identify the sternal saw. That is on the top right corner. On the left side, you will see a hemolog clip. See, the reason I put this there is that the critical structure that you have to ligate is the left innominate vein. If you don't ligate this properly and it starts bleeding, it bleeds so badly, everything gets slowed down. You can't see any anatomy after that. Very secure way of clamping the left innominate vein. Endo-GIA stapler is used by the cardiac surgeons when they come. It's cost $2,500. One shot. This is, I don't know how many, $5 or something. So use this. If you don't have this, you can use an arterial forceps, artery clamp. And on the right side, you'll have to stitch and take it out. On the left side, you can leave the clamp. The less hardware you have in that middle of the sternotomy, the better. There is the sternotomy retractor I have not shown here, but you can see at the bottom, okay, near those 4x4 gauze pieces, there are two Bowie pads. Those are scratch pads of the Bowie. The black part is the part you scratch the Bowie on. On the other side is a sticky surface. So when you use the sternal retractor, before you prepare stick the Bowie pad onto the blades of the sternal retractor. Because then when you put the sternal retractor into the sternotomy and you start cranking it, it opens, it doesn't slip. See, the only way to get speed is every step you do is done once. You should not have to do a step twice. If you put a lap pad to help it secure, that lap pad comes in the way of your crank. You don't want any, Ravi was saying you can put a towel clip. Yes, but then that's more hardware sticking in the way. This is a simple solution that Sardarji, who was scrubbing with me, he taught me this trick. It works perfectly. Indian Jugaad works perfectly. Okay. The others are usual instruments. There is, time. Okay, sorry. This is the table which has to be kept warm. This is the handover. The person's hand is the one with the NRP technician. The other one with the gloves is taking the tubing. This is the surgical steps. We've already talked about it. The perfusionist has to confirm good venous flow. This is critical to the conduct. It's usually possible under 10 minutes. I've talked about ANRP and TANRP. I don't think we need to. This is a picture of TANRP with the perfusionist on the left side at the head end. The tubes are coming and going out of the sternotomy. The abdomen has been opened, but it's covered with a gauge. This is when ANRP, the perfusionist at the foot end of the bed. And this is the charting they use every 5 minutes with ABG done every 5 minutes. And this is the case which was kind of strange for me. The patient was already on ECMO, was brought into the OR with the ECMO on flow. Cannulation was done in the femoral artery and vein. And this is the patient. The ECMO machine is the one closer to us, and the NRP is being set up further away from us. Once the patient withdrawal of life support, the NRP was stopped, clamps were applied, and the patient was allowed to pass. And once the patient died, we connected the tube to the NRP machine and got going. So in summary, time to start thinking and planning for DCD, and I congratulate Dr. Avnish for really pushing the envelope, moving us forward. SR super rapid and NRP are the two options. Choice depends on how many organs are transplantable. Surgical approach is similar. NRP is best done in a planned manner, setting up the OR, which usually takes, in my experience, half an hour to 1 hour before you can start. In an uncontrolled potential DCD situation, where there is option to start ECMO in the ICU, well then that's great. Okay. With those, I thank you all for a patient listening, and best of luck. And Jai Hind.
Thank you, Philip. You want to have any question? Quick question?
Sure. Even the audience, a lot of people.
Yeah, if there are any.
We have liver experts there, so.
Okay. Professor Phillips, excellent. I'm very happy that you was able to implement in Texas the DCD and also the NRP, no? Because that is, I think, is the gold standard today. In my hospital, the size of you in Catalonia, 72% of our donors today are DCD, and NRP have been implemented since the year 2000. And today, there is no difference between the organs retrieved from DBD and DCD in the number and in the outcome. You mentioned the first slide I like too much. What is the key point for you to implement in India successful DCD and NRP? The champions are the intensivists again, because they predict the ones who will die on time. And that is the most important. In Spain, it's only the cases who go to the OR, ones that in the clinical session in the morning, the intensivists predict this guy will die on time. And second is who support the will drought. It's not the last doctor, it's not the youngest. is the team of anesthesiologists who monitor the V's, the blood pressure, the transesophageal Doppler, give sedation, give analgesia is allowed in our country. And that means that in Spain, 100% of the potentials die in 17 minutes in average. That's allowed to use the organs. And another issue that I know that Anil Kumar, you can have in your registration is possible. The big difference between probably Spain and other countries, you are allowed to put heparin before the procedure, and other countries is not. And second, we can pre-cannulate before the will drought. So that gives a big advantage. It's like the last case that you mentioned that the body came already with the ECMO placed, because that is what we do. But I don't like to talk more because my friend Eduardo Miñambre will speak the Spanish experience, but I think you're a model, how you transfer your experience on NRP to Texas and make it possible. But let me insist again, the same from the DVD. Aunis know from me that intensivist is the key point. That once who will identify or predict DCD are the intensivists, should be in this program. So one part is intensivist, second part is anesthesiologist supporting the will drought. Third part is the perfusionist. He will tell me the pH, the lactate, what is the situation. And the surgery will be a normal surgery, like a heart beating body, because the body is already under NRP or thoraco-abdominal NRP. And you did it in this way because this morning you visit the ICU, with the chairman of critical care. You have the department of anesthesia and also the perfusionist. I think it's a good issue that we did this morning. These are the three elements. Surgery comes after. Thank you for the opportunity to share.
There's a question online. So, what is the difference between NRP and eCPR?
And
eCPR. ECMO CPR.
Okay, ECMO CPR. There are many centers, I suppose worldwide, but I saw it first in Baylor, Dallas, where ECMO is part of CPR. So the moment somebody has a witnessed cardiac arrest and you start CPR, ACLS and all that, they have a way of predicting who will require ECMO. I am not the expert in that, but while compressions of the chest are going on, they put in the cannulas in the femoral artery and the vein and got ready to start the ECMO. And I think, our intensivists and all may be more familiar with that. I have never done ECMO CPR. I've only seen the benefits of it.
The intention of eCPR is to revive the patient. No. The intention is basically a bridge to decision. Correct. This is in those countries where there's presumed consent for donation, like in France, Spain. So there they have a very strong, robust eCPR program. So almost most of the patients are put on eCPR, and a decision is taken whether to continue with the eCPR or it goes on to donation.
No, I would beg to differ, sir, because one of my residents who went into a trauma fellowship, he has a small series now of patients where they have done ECMO with CPR and completely revived the patient.
Yeah, that's true. Bridge to decision. Whether the patient
becomes decision. Sorry, I apologize. I thought it's bridge to
Bridge to decision.
Yeah, decision.
Can we close? Okay. So we'll close this.
Just let me give a small comment of ECMO eCPR in Spain. Patients who have a cardiac arrest outside of the hospital with a refractory treatment, they came from ECMO CPR. What are the results for 100 cases? Patients survive, but some of them who don't survive remain as the brain death donors because the perfusion and heart restart, but the brain not. And also, you can have also the control. So there is a new source of donors from outside of the hospital. Is the eCPR program is established in the country.
Raj, you wanted to make comment?
No, I think just the only thing I just wanted to bring, I might bring it up later on also, is the difficulties that you will face in India in the setting of withdrawal of treatment and the ability to predict death. And just to be very careful in terms of how this is implemented. It has to be implemented in a controlled environment. The potential for for a negative outcome is also quite high. So not because the chances of not progressing on to death are quite significant in the controlled DCD setting. So we'll be introducing three things: controlled DCD, controlled DCD, withdrawal of treatment, as well as NRP. And all these three things have rarely been introduced at the same time in a population anywhere in the world. It's always been stepwise elsewhere.
Thank you. I think we close the session. Thank you, Philip.
Thank you.
Thank you, everyone. I now request Dr. Sunil Shroff to chair the session and also Dr. Brian. Few words from Dr. Brian before Dr. Shroff says something.
Yes, thank you for Dr. Avnish and the organization for this opportunity of being part of this discussion. We had a great experience from the Texas team, and I'm looking forward for hearing the experience from the Cambridge team. I know that you have been doing a great job in the UK implementing and being pioneers in this DCD and use of NRP. So looking forward for this discussion.
Thank you. Over to you, sir.
Thank you, Avnish, and good afternoon to all of you, and good morning to my friends from Europe. Great pleasure to introduce Professor Chris Watson, who has been trained under the stalwarts like Dr. Sir Roy Khan and Peter Morris from Oxford. He is from Cambridge, works as a consultant transplant surgeon there for liver, kidney, and pancreas transplant. He has a great interest in increasing the organ donors and making the most of what is available. One aspect is to quantify the risks of donor-transmitted disease, in which he has interest. In 2010, he started the first NRP program for controlled DCD donors in the UK and has worked on the national NHS to apply for government funding to reduce NRP across the UK. His other current interest is normothermic liver perfusion, and he oversees the NMP liver program in Cambridge, which he began in 2014, and has performed over 500 perfusions. So, great pleasure to have you, Professor Chris Watson, and we would like to hear the experience from the UK of DCD donations. I know the UK donations have increased. Number of donations have increased by 33% using DCD donors. So, over to you, Professor Chris Watson.
Well, thank you very much for inviting me. I'm honoured to be here, and congratulations on this initiative. Let me put my presentation up.
So we're a little feeble on the voice. Can you just get closer to your mic, please?
Okay, let's hope that's better. I have a declaration of interest. I'm a consultant to Organox, but that shouldn't affect my talk. So the problems with DCD livers in the UK when we started was that if you had a DCD liver, you were twice as likely to die within 3 years and twice as likely to lose that liver within 3 years through primary non-function or poor function or cholangiopathy. And that was the setting that we faced when we tried to do something about it. In the UK, when treatment is withdrawn, the clinician, the intensivists stop inotropes. For most part, they'll extubate the patient, and it usually takes place in the theatre complex, but it may take place in the intensive care unit. We're not allowed to do comfort measures. Death's verified after 5 minutes, and it's the absence of the blood pressure, as we've heard previously from the group in Texas. 33%, so a third of patients don't proceed to death within 3 hours. Just to reiterate what Darius was just saying.
So please presenter mode.
Can you not see? Oh, I beg your pardon.
On the top, you will see the
Yeah. So we're in business now, yeah.
Yeah.
NRP really began in the UK on the 5th of November 2006. The 5th of November is a notable day in the UK because it's the day 400 odd years ago when anarchists tried to overturn Parliament And it was a day when Stephen Large and Kumid, who's with you there in India, overturned my perception of DCD donation. They've restarted the heart in a DCD donor, proving A, that it was possible, but also, as you've seen in the video, that the liver looks fabulous and the kidneys look beautifully perfused. And it changed our perception of what we should be doing with DCD donation. And you can see even we had peristalsis in the small intestine. So we spent 4 years negotiating ethical hurdles. We started in 2010. We did our first liver transplant in 2011. It was about 3 years it took us before we realized the short-term outcomes were so much better. And in 2019, in collaboration with colleagues in Edinburgh, we published a paper that showed actually we had no cholangiopathy in any of the patients that we'd done to date. And that coincided with a publication from the Spanish group from Emilia Hesheimer and colleagues showing that in Spain they'd also got an NRP program and were seeing no cholangiopathy. When we started, we were using whatever equipment we had around. So this was an old Medtronic's pump, and we used trained cardiac perfusionists from Papworth. We progressed to using some commercial equipment, initially the ECOPs and then the donor assist made by Organ Assist. They no longer are available. And we moved to the Maquet Cardia Health. But these are fancy bits of equipment that you don't necessarily need to use. We started by cannulating the aortic arch and left atrial appendage. I'm not a cardiac surgeon, so that didn't go too well. We moved to cannulating the right common iliac artery and IVC, trying to get the venous cannula tip in the right atrium. And then we faced with a patient with ankylosing spondylitis who we couldn't lie flat on the operating table and we couldn't access the abdomen quickly. And we decided at that point that we needed an alternative route. And at that point, we started to cannulate the femoral vessels. Artery first and then vein, because if you cannulate the vein first and get spillage, it's very difficult to identify the artery. So we now preferentially do femoral cannulation. If the donor is very obese, then the abdomen may be better, but generally femoral cannulation. We used to use the larger cardiac cannulas, but now we use the ECMO cannulas for the femoral cannulation. There are one or two anatomical anomalies that have complicated things. We've had a horseshoe kidney, but that was perfused very well. We've not seen a pelvic kidney, but we have had a type 2 retroaortic left renal vein, as you see in B in the diagram below, where the femoral cannula finished up in this left renal vein, and we spotted that when we'd opened the abdomen. When we do femoral cannulation, our next move is to open the chest, put a cross clamp across the thoracic aorta, and at some stage later we'll look in the abdomen. We don't necessarily need to do that straight away. In the UK, there are serious ethical concerns, and in particular the guidelines to certify death insist that we do not restore a blood flow to the brain. And to ensure that we aren't restoring a blood flow to the brain, we place a 24 gauge cannula into the ascending aorta and just leave it open to air, as you can see here. And this is on full ECMO, and you can see there's a column of blood in the cannula of about 3 centimeters. So that's 3 centimeters of pressure. That's not sufficient to perfuse the brain, and we're reassured then that there's no cerebral perfusion with our clamp on. You can just see in the chest hair a clamp on the descending thoracic aorta. We primed the circuit initially with Hartmann's compound sodium lactate. That gives us a lactate bolus from which we can subsequently see lactate fall. And then subsequent to that, any volume replacement is either with gelifusing or with blood. We give 50,000 units of heparin into the prime. We're not allowed to give heparin before donation, so 50,000 into the prime. We give 1 ml of 8.4% bicarbonate per kilogram donor weight. We add some antimicrobials. We give methylprednisolone because we give that to DBDs and it seemed a good idea. We give phentolamine to counter the alpha vasoconstriction that you get during that withdrawal process. You get a lot of catecholamines released during the withdrawal process, and phentolamine helps to counteract that. And then we give blood as required. If there's a chest team taking the heart or the lungs, there tends to be a lot more bleeding and therefore a lot more blood required. But typically we end up giving about 2 units of packed red cells during a 2-hour perfusion. We don't have trained cardiac perfusionists anymore. We use trained theatre technicians to run the pump. They do blood gases every 30 minutes. Every 60 minutes, we do a liver function test with this near patient device called a Piccolo from Abaxis, and that'll give us a transaminase reading. And we do blood cultures at the beginning and end just to make sure if there are any microorganisms present, we can identify them early in the post-transplant course of the recipients. For viability, we look at the ALT at 2 hours. If it's less than 200, we're happy to use the liver. If it's more than 500 and less than 1,000, then we would reassess the liver on our Organox metered device. The results of livers that we've had to reassess aren't that great, so actually we think our criteria of an ALT of less than 500 are actually quite good. The lactate we'd like to see falling. It doesn't always fall far, but it should fall. And the glucose we'd expect to rise at the beginning of the perfusion and then fall. And this is a response to both the warm ischemia and the adrenaline release during the withdrawal phase. If the glucose doesn't rise, it's an ominous sign. So we run the circuit for 2 hours unless there's catastrophic loss of volume. We aim for flows of around 3 litres a minute in an average adult, and we're perfusing the abdominal organs and the contralateral leg. And we manage the whole thing looking at the venous oxygen saturation. And the CardioHelp pump has an inline monitor for venous oxygen sat, so we can monitor that. And we'd aim to get sufficient oxygenation to get a 60 to 80% venous oxygen saturation. If the SATs go low, then we can either give more red cells or we can wind up the pump speed or do both. We can adjust the pH by adjusting the gas flow across the oxygenator. And the gas flow is typically an oxygen-air mix. It's not pure oxygen. We just aim to get 100% saturation of the arterial blood. So in the Cambridge series, we've done 351 retrievals to date. 261 have resulted in liver transplants, so that's 75% utilization. We use these livers in any sort of recipient, so 9% of these have gone into retransplants, 6 have gone into our highest urgency patients. The mean MELD of recipients has been just over 17, but our range of MELD in recipients is up to 43, so we will put these livers into anyone. They're very robust livers. And just to give you a demonstration of that, this is the UK DCD donor risk score. So this is a score that was drawn up initially based in Birmingham and validated on UK data, looking at the outcome of DCD donor livers in recipients, and based on donor and recipient factors, scoring points for each of those, you can see that the best prognosis group, if there were 0 to 5 points, had a survival of just over 80% at 5 years. The high risk groups, the 6 to 10 points, had a survival of under 60% at 5 years, and if the score was over 10 points, they were classified as futile with a survival of less than 20% at 5 years. If you do NRP, and these are our data for NRP, you can see that every risk group, from low risk to high risk to even futile, has got an outcome at 5 years of around 80% or higher. So NRP completely transforms your DCD liver transplant program. Not only are you using more livers, but they're working just as well as DBD donors. In terms of early allograft function, Pareja and colleagues from Spain produced a score called the Model for Early Allograft Function Score, where 0 is bad and where 0 is good and 10 is bad, and we have a score of 4.2, which is very good. And under the Althoff criteria, only 12% of our patients get early allograft dysfunction following an NRP DCD liver transplant. We know that DCD liver transplant is associated with acute kidney injury, and from a study by Leifed and colleagues, 53% of DCDs with rapid retrieval suffer acute kidney injury, and 31% of DBDs. And with the NRP, we see 33%. So just similar data to DBD livers are much better than DCD livers. So not only do you get better early function with less early problems, you get better long-term function. In terms of biliary outcome data, we have a leak rate of around 5% and an anastomotic stricture rate of around 12%. But in terms of non-anastomotic strictures, which are the real disabling thing, if you exclude our PSC patients, it's 3% at 12 months. The PSC patients have a much higher incidence, and indeed at 12 months it's 15%. And I think that probably represents, rather than ischemic cholangiopathy, but a recurrence of their PSC. None of our patients who've had NRP DCD livers have gone on to require retransplantation for cholangiopathy. What about donors that take a long time to die? So traditionally we would use donors that died very quickly because we were trying to predict would these livers work. We've become very relaxed about this. So our median withdrawal to arrest time is 14 minutes, but that ranges up to 227 minutes. So we're quite happy to wait for donors to die. The asystolic time, the time with no blood pressure, our median is 17 minutes, but the range is up to 32 minutes. And the 32-minute liver recipients did very well. And our functional warm ischemic time, so when the systolic pressure drops to less than 50 to reperfusion on NRP, is a median of 37 minutes and a range of 72 minutes. And we try and tell our trainees who do this to take their time, because NRP allows you to take time doing retrieval. You don't need to rush so much because you're restoring the circulation, you're replenishing ATP on NRP, and the livers and kidneys do much better. In terms of cold ischemia, our median cold ischemic time for these livers is around 7 hours, but that's ranged up to 13 hours with very good results. And just to show you that, in terms of withdrawal times, whether it's more than 60 minutes or less than 30 minutes or in between, you can see there's no difference in transplant survival. And transplant survival is graft survival without censoring for death. So if the patient dies, it counts as a graft failure. And the same here for functional warm ischemia, whether it's more or less than 30 minutes, there's absolutely no difference in outcome at 5 years. The UK expansion has been slow, largely because we don't have national funding yet, and it's been funded largely by charity and local hospitals. But 7 out of 10 of our national retrieval teams now undertake NRP. We have national protocols, a standard operating procedure, a competence document that they have to meet before they can go on and do NRP. And we've got a passport that has to accompany the organs, so the liver and the kidneys, when these get distributed. We have a debrief after each case for new centres starting, so we can make sure they're doing things right and point them in the right direction. And for every centre doing NRP, we have a national debrief by teams every month to present cases for interest and for learning. So just to summarise, NRPs, it is easy to learn and to perform, and as time's gone on, we've realised there's no need to rush retrievals. Liver and kidney utilisation are much better than with rapid retrieval, and not only is utilisation better, but outcomes are superior. So liver, I've told you, but even the kidney outcomes are better with a typical median GFR of around 6 mils a minute better at 1 year. And cholangiopathy does occur, but it's very uncommon and is seldom limiting. Thank you.
Thank you, Chris, for sharing your experience from the UK. Philip spoke about his experience from the US. You spoke about yours. So, Philip, do you see any observation? Do you want to make any comments? I know you'll be taking notes.
Oh, yeah, that was a very great lecture, and particularly I felt very honored that Umar, who did the first one, is sitting right here at this table next to us. And there's a lot to learn from the experience because it's considerable in terms of time. And one of the most interesting things that Professor Watson just said is biliopathy may occur, but it is usually mild and seldom limiting. So just having a diagnosis doesn't mean the liver is trashed, and that is very encouraging too.
So do you have less discards compared to what you guys have in the US, from what I can see? The UK has better utilization, looks like. Am I right? I'm not a liver guy.
I don't have the national data. So I'm still limited to what is called region 4. And I would say that we're perhaps performing as well as the UK, probably.
But the functional warm ischemia was slightly longer than what you said.
Yes, even the functional warm ischemia is, I think you said it should be 6 minutes ideally.
No. That's it.
No, 30.
That is incision to perfusion. But the functional warm ischemia time is when the blood pressure drops below 80 or 50. You have to decide which is going to be your cutoff. Professor Watson is describing functional warm ischemia from systolic blood pressure of 50 onwards. So maybe we should adopt 50.
Brian, you want to say anything?
To be quite honest, we now ignore the term functional warm ischemia because it's no longer relevant. We used to use it when we were trying to predict whether a liver would work, but now you can test the liver on the machine, and we've got away from being dictated to by the timings. We just want to see how the liver's working, and that makes all the difference to us.
Good.
Chris, thank you for bringing up that very first case, which was also my baptism of fire. And that told me that it was going to work. And I recall within 4 minutes we had spontaneous sinus rhythm, and you were so excited about the urine being produced. But you had quite an experience from then on with TA and RP. And I know there's a moratorium in the UK, but if it weren't for that moratorium, could you suggest what the peri and survivorship data would look like with the TA and RP cohort compared with your abdominal NRP?
So initially we had a little bit of issue with TNRP with getting protocols sorted out, but the outcomes of the organs, the livers and kidneys, were very good. The main reason for the moratorium, as you may have said, Kumar, is the concern about perfusion of the brain, and I think the evidence now is that if you're draining the cerebral vessels, so if you drain them to air, there's no perfusion pressure. There can't be a perfusion pressure if you've opened all the cerebral vessels, and therefore that it's probably safe. And we're very keen to see that restart because it makes a huge difference to the cardiac function if you can restore the circulation in situ rather than have to put it on another machine. And the kidneys and liver work very well that way, and there'd also be less bleeding if the circulation, if the heart's left in place, rather than have to remove it with the attendant bleeding that happens.
Last comments from Brian, and then we'll close.
Yeah, I want to congratulate the Dr. Professor Chris Watson for his presentation and for the great results they're having in Cambridge, and to highlight two things that you mentioned that I think are very important in this discussion. One of them is who is performing the NRP in your setting, no? Who is the person responsible for dealing with the NRP, and I think that you had this great approach of starting with the perfusionist and then being these teams the one that train your technicians in your OR, so you release that burden from your surgeons and you have someone who is now skilled and trained in managing this NRP and the whole procedure. And the second thing is this dilemma or this fear of guaranteeing that there's no brain perfusion. I agree with you that now it's very clear that in abdominal NRP there is absolutely no discussion that there is no chance of having brain perfusion if we guarantee there is no flow to the thorax, right? As you did when you clamp your abdominal aorta, or either when you use a Fogarty balloon to avoid this flow, then we are safe that there will be no issue. But the big discussion is on thorax abdominal NRP, and as you mentioned, now if you can cut and drain the vessels to the brain, then we are safe. But there are many teams now doing research to try to demonstrate that this is safe. But I think that as a message is that don't be afraid of abdominal NRP, because there will be no ethical risk on doing this NRP, because there is no chance we're going to restore circulation to the brain if we take these measures that you did, for example, having this cannula in the thorax to guarantee there is no leak in the system, or using a arterial line to guarantee that to monitor somehow that there is no leak in the system. No? But if there's no leak, it is a safe procedure.
Thank you, Brian. Darash, you want to say something? Professor Chris, can you answer the question on the chat window from the 37 or 30 odd people online, I think, or a little more. So can you answer that question, if you don't mind, on the chat window? And Darash, you want to say something?
Yeah, so Chris, do you want to go first?
Well, I would say the question is what's our experience with organ function prior to NRP, and it wasn't good, and that's why we went to NRP. We had a long-standing program of DCD kidney transplantation, but DCD liver transplantation, we had a lot of cholangiopathy and were very hesitant. But when NRP came along, it's completely transformed our practice, and the majority of our transplants now are NRP liver transplants. And in the UK, DCD donation is now overtaking DBD donation as the commonest form of deceased donor transplantation or donation.
Slightly stretched for time, so Reyes, please go ahead.
So it's a very quick thing. So, Chris, the UK has 7 liver centers and 10 retrieval teams. Yeah. Most Indian cities have that existing in one city itself. Tell us about the difficulties in terms of widening the practice of NRP across these 7 centers and 10 retrieval teams, because I think that's an important message that does need to get across. And 2 is, how would you advise, you know India a fair bit in terms of what one should do to move the theory into practice in an Indian setting?
So the model that we've adopted, we have a national training days, so people can come and train with us. But then we send a perfusionist and a surgeon out to the centre that's learning when they have a DCD donor, so that they can assist them going on to NRP. So it's a system of mentorship where someone will go out to the centre, a kind of flying squad, if you like. So colleagues of mine and colleagues in Edinburgh who also do this will go to local hospitals. We've been to Birmingham and down to King's and for their retrievals, and Edinburgh been down to Newcastle, and that's how it's worked, and it works very well that way.
Thank you. I think we'll move forward, and thank you everybody for listening to Professor Chris Watson. We now go on to the Spain experience. So over to.
Thank you, Dr. Sunil. So I now request Kumud to take the chair along with Darius, and Darius, of course, needs no introduction. He's been a part of our consortium and has about 30 years experience in liver transplant. So over to you, Kumud.
Thank you very much. So the next speaker is Professor Menambres, who is a very experienced person in this space, having been at it for many, many years. He's currently the professor at the University of Cantabria. He is also currently at the moment Marqués de Valdevilla in Santander, Spain, and head of the transplant coordination unit. And with the particular focus of his academic and clinical practice in improving therapies and protocols to reduce postmortem functional damage to solid organs, the use of ECMO to improve ischemic damage and DCD donation, and finally, more recently, the use of ECMO to combine thoracoabdominal solid organ retrieval in the DCD setting. So over to you, Professor Menambres, and we'll have some questions for you afterwards.
We can't able to hear you.
Eduardo, you're muted.
Can you hear me now?
Yes.
Okay. Thanks. First of all, I'm so proud to be part of this meeting. Thank you very much to the organizers for inviting me. And I'm going to get you some data of how the Spanish model is regarding the DCD donation. First, sorry. Oops. Okay. I have nothing to disclose. First of all, these are data on my center. We have our transplant programs available, and we have around 55 to 60 deceased donors per year. We started with our controlled DCT program and uncontrolled DCT program in 2012. And we, for the very beginning, we decided that the NRP is the ideal method for organ retrieval. We have never performed a DCT donation with the super rapid technique. And we performed in our center the first Spanish pancreas transplant from DCD and the first combined liver and kidney transplant from DCD. In 2020, we did with other 2 centers in Spain the first case of heart transplant obtained from controlled DCT donors using thoracoabdominal NRP. And we were also able to set up our pediatric DCT programs. In 2021, we obtained a heart from a neonatal donor with 3 days using post-mortem thoracoabdominal NRP. These are data from Spain. As you see, in the last decade, we have increased so much our donation rate because of the controlled DCT donation. And these are data of my region. In the last years, we have, for 10 consecutive years, my region has achieved the first position in Spain regarding the rates of DCT donation and DVD donation. Last year, we had 94 donors per million population. And as you see in this slide from the International Registry, these are data of the annual rate of DCT donation rate from DCT donors. Spain achieved 22 DCT donors per million population, and in my region, we nearly achieved 60 DCT donors per million population in 2024. That's, in my personal point of view, the key points of the Spanish model. We don't consider that we have to engage the intensivists. We do think that the ICU physicians must be the leaders of the transplant coordination units. The NRP procedure is always led by the transplant coordinator. And as Marty said before, in Spain, premortem interventions are allowed. We can use heparin and we can perform premortem cannulation of the potential donor. And I do think that it's so important that before starting uncontrolled DCT programs, it's mandatory to have some protocols of the care of the patient and the end of the lives. So palliative care and comfort care measures are part of the treatment in all patients, no matter if they are going to be donors or not. But that's very important to have these type of protocols before set up DCT programs. As I said to you from the very beginning, we did consider that the results obtained with NRP will be much better than the rapid recovery technique. So I don't have experience about the rapid recovery technique. These are the 3 initial experiences published in PubMed using NRP in controlled DCT donors, the experience of Michigan, the UK, and our own experience in Santander. From the very beginning, even with the very early learning curve, we demonstrated that the rate of cholangiopathy, the ischemic cholangiopathy from the liver, was much, much lower than they observed in rapid recovery technique. Some studies, as this very well-known study from Professor Watson, demonstrated that the results in liver transplantation with NRP was much better than with rapid recovery technique. And finally, the studies from Spain with nearly 800 liver transplants obtained from controlled DCT donors demonstrated that the graft loss, the biliary complication, and the ischemic cholangiopathy decrease so much with NRP. So that's the ideal technique for DCT donation. The same for the kidneys. The results are much better with NRP than with rapid recovery technique. And this is how the method is in Spain. As I told you, we are allowed to perform premortem cannulation. So once the withdrawal life sustaining therapies have been performed, we wait until cardiac arrest. The non-touch period in Spain is 5 minutes, and in that precise moment, death is declared. So we fill the thoracic aortic balloon, and the abdominal cavity is well preserved. As you see, we maintain the NRP for at least 2 hours, checking the lactatum values, the liver enzymes, we use fluids, and of course, our goal is around 2.4 liters per minute. That's quite easy. In Spain, we have avoid the rapid recovery technique in blue, and we have increased so much in yellow the percentage of procedures performed with abdominal NRP in yellow, and also thoracoabdominal NRP in blue, that since 2020, when we started our heart transplants programs, we have increased so much in the last 5 years, as you see. So today in Spain, only 10% of the procedures, only focusing kidneys, are still recovered with the rapid recovery technique. And my personal impression is that it's a wrong decision. I mean, NRP is much, much better for the kidneys. And in Spain, we have very good experience with that. We have portable devices. We have ECMO mobile teams for getting the NRP in all centers across the country. Well, the next step was to combine the abdominal NRP with the lungs. And the people from the UK were the first one who described this technique. And later, in my center, we were the first one who had a great numbers of lungs obtained from controlled DCD donors using NRP. Our approach is a bit different from the UK approach. Sorry. This experience, published in 2022, is the largest single center experience published in the literature up to now, and we compare our 60 lung recipients, which lungs obtained with simultaneous use of NRP for the abdominal grafts, with controls, DVD donors. The results were identical. We achieved very good results in the short, mid, and long term, with identical 5-year survival than those obtained from lungs from DVDs. And I would like to emphasize that the age of the donors were identical in both groups. And this is the Spanish experience, with more than 200 lung transplants obtained simultaneously with abdominal NRP versus nearly 2,000 lungs obtained from DVD donors. And the most important thing is not only the liver and lung recipient survivals, also is important the organ utilization. The organ utilization for livers and lungs is identical to the organ utilization of liver and lungs obtained from DVD donors. We have developed so well these procedures that the organ utilization rate for liver and lungs is identical than DVDs. And this is how our protocol is. Once cardiac death has been observed after 5 minutes of no-touch period, we always preserve the abdominal cavity. And later on, it's up to the surgeon to perform a sternotomy. We restart the mechanical ventilation to the potential donor, and we cannulate the pulmonary artery as soon as possible. That's the moment in which our thoracic surgeons perfuse the perfused solution throughout the pulmonary artery, and that's the moment in which the lungs are pretty well preserved. That's the moment in which our abdominal surgeons start with the laparotomy, and we have 2 different types of temperature: normothermia for the abdominal cavity and slight hypothermia for the lungs. After 20 minutes, the thoracic surgeons perform his measures, some kind of recruit maneuvers or similar, and later on, he's up to recover the heart and the lungs as a block. They take this block, and we maintain the abdominal cavity with NRP for an extra 60 minutes. The cava vein clamp is the more critical point because we decrease the perfusion. We can lose the flow of the thorax and the heart. And as you see, we have increased so much the number of lungs obtained from DCD donors in Spain. And our most challenging approach, our most challenging step was to introduce the thoracoabdominal NRP obtained for recovering the hearts. We have learned a lot from the people of Padworth in Cambridge. We have adapted the protocol to our arts, and as they published in 2020, the results are quite promising. In 2021, we published our first experience with hearts obtained from controlled DCD donors using thoracoabdominal NRP, and I would like to emphasize that we never use ex situ devices. We always preserve these hearts in cold storage, and we achieve at the initial cases very good results. In 4 years, we have increased up to 211 hearts obtained from controlled DCD donors in Spain, and we have obtained hearts from 25 different centers. So we have been able to obtain hearts not only in the big university centers, but also in so many centers around the country. And this is how the procedure is. We always cannulate the donor, as I have told you before, and we always preserve first the abdominal cavity. Once cardiac arrest has been observed, and after 5 minutes of non-touch period, death is declared. We fill the thoracic aortic balloon and we preserve the abdominal cavity. Later, it's up to the cardiothoracic surgeon to perform an atherectomy, to connect to mechanical ventilation, to clamp the supraaortic vessels. And I like to emphasize that clamping the supraaortic vessels is not enough. We have to section the distal ends. And later, we extend the abdominal Nrp to thoracoabdominal Nrp with 4.5 or 5 liters per minute. And from the very beginning, in just seconds, the heart starts beating. We evaluate the heart function with echo, transesophageal echo, and we decrease the pump flow. And our goal is in 15 minutes, 16 minutes, to stop the thoracoabdominal Nrp and maintain this donor with the heart beating, perfusing the other grafts, liver, kidneys, lungs, pancreas, and is more or less very similar to a DBD donor. These results have been published 3 weeks ago. This is the Spanish experience published in February of this year in American Journal of Transplantation. We published our initial cases, 98 heart transplants obtained from DCD donors using thoracoabdominal Nrp without ex-situ devices, always with cold storage. And the results at 1 year, the recipient survival were identical to the hearts obtained from DBD donors. And these numbers are quite impressive. I mean, we are comparing more than 300 hearts from DBD donors with nearly 100 hearts from DCD donors. And at the same time, we have been also able to obtain lungs from donors using thoracoabdominal Nrp. I would like to finish my lecture with the ethical concerns about Nrp. Our previous chairman talked us about the possibility to perfuse the brain after death has been declared. I would like to emphasize that, as my colleague said, in Belgium and the UK, they had to stop the thoracoabdominal Nrp process because of the possibility to restore brain circulation. Spain changed the protocols in 2023. To perfuse the brain with the clamping of the thoracic aortic vessel is not a possibility. It's for sure. We know that throughout the thoracic, the peripheral or the collateral circulation, the brain can be perfused and is perfused. So it's mandatory not only to clamp the supraaortic vessels, we have to bend the distal cephalic ends to the atmosphere. That's mandatory. There are some studies, such as this elegant study for the group of New York, in which they demonstrated that with Doppler transcranial echography, there is no blood flow 30 minutes after the initial thoracoabdominal Nrp procedure. From my perspective, this is not enough, because they started the echo-Doppler echography 30 minutes after starting the thoracoabdominal Nrp. And there were 2 cases in which they had severe brain damage. So the possibility to evolve to brain death in these 30 minutes is too high. We must monitor the brain circulation just immediately after the thoracoabdominal Nrp is started. And this is the only possibility to do that, in my personal point of view. This is our experience using, as I'm going to show you, some kind of sensors catheters in the circle of Willis. In 10 cases, before the withdrawal isocyanates therapy, we place a pressure catheter in the circle of Willis throughout the carotid artery. It was performed by our neuroradiologist, and we evaluated the pressure during the whole procedure. This is an example. Once the withdrawal isocyanates therapy was performed, we observed a decrease in the brain pressure, in the thoracic pressure, and in the abdominal pressure. After the non-touch period, we started with the abdominal NRP, and you can see how the abdominal pressure is increased. Later, we clamp the supraortic vessel, we section them, and once the heart started to beat, we observe an increase in the thoracic pressure. But on the contrary, the brain pressure was maintained at the same level that it was observed during the 5 minutes of the non-touch period. The most important thing is that once the heart was pumping, we had pulsatil pressure in the thoracic and in the abdominal pressure, but never it was observed in the brain pressure. I have to insist that there were very few cases, but this is very strong evidence that if we clamp the supraortic vessels and we section them, there is no possibility to restore the brain perfusion. We have been received a budget for the Spanish government. We have increased our study, and we not only evaluate the circulation, the brain pressure in the circular Willis, but also in the basilar artery. So we evaluate the anterior, the middle, and the posterior brain circulation. Up to now, we have included 29 cases, 7 of them with thoracoabdominal NRP and 22 with abdominal NRP. I do think that at the end of the year, we are going to publish the whole experience. And just for finish, there are differences about the possibility to restore brain circulation. The people from the US, as you see, they published the recent protocol of using thoracoabdominal NRP, and they describe 4 possibilities to guarantee that there is no brain perfusion once the thoracoabdominal NRP is functioning. We disagree, and we have published a letter of the editor considering that the possibility C and the option D is not enough, because these 2 options that they are considered by our colleagues from the US, we do think that there is the possibility to restore brain circulation throughout the collateral thoracic arteries. Well, my 2 last slides. These are the number of liver and kidneys transplanted from controlled DCD donors in Spain. As you see, we have increased so much our figures. We have increased so much our figures in livers, and the same results in the lungs in green and in hearts. I do think that there is much room for improvement in obtaining grafts from DCD donors using the Nrp devices. And we can also use the Nrp for uncontrolled DCD donation. I'm not going to spend time in this procedure because it's quite different. I'm talking about patients who suffer a cardiac arrest outside of the hospital. We have just published our results for kidneys. This paper has been accepted in Transplantation Direct and is going to be released in PubMed in just 2 weeks, when we obtain a very good survival rate for kidneys, 92% at 5 years, and we have also experience in lungs. And for summary, I do think that the health system and his professionals must try to preserve this right. Nrp is the best method for organ preservation in DCD donors, and I do think that it's more cheaper than the use of excisions and let the assessment of the graft before recovery. I do consider, I really know that the ethical concerns about Nrp are easily solved with the adequate professionals, and I think that the impact of DCD donation is amazing in the number of grafts, reducing the patients in the waiting list, and it has a very good, excellent recipes outcome. But my last suggestion is that the ICU doctors must have an important role in DCD donation. And thank you very much for your attention.
Thank you very much for that absolutely comprehensive run through your program, which is really very, very fascinating, particularly with the DCD and TNRP throwing those ethical challenges. And I mean, it's surprising now it's coming about that there are these collaterals. See, I was always worried about the flow that is potential up the inferior epigastric, superior epigastric, which joins with the. There is also a recurrent vessel in the brainstem, which is why Stig Steen, in his porcine models, actually has to decapitate the pig to make it a true DCD. there are these recurrent collateral circulations around. So I commend you on that. But of course, the ethical problem for me is if the patient is dead, why are you worried about cerebral perfusion at all? Because whatever you do to the cerebral perfusion, you're essentially just allowing brain death to take place whilst you're doing your TNRP. So it doesn't, the ethical dilemma still rests. If the patient is declared dead is dead, let's just forget about, which is what I say, any kind of clamping of anything, just perfuse the body. It's a dead body, right? And so, but these are challenges that we still have to address. And that's why we have an issue in the United States. There are only 4 or 5 centers doing thoracoabdominal work. I just wanted to ask you just quickly 2 things. One is, if you had the choice of TNRP over just ANRP in general, what would you choose now in respect of, again, the same question that I asked Chris, in terms of outcomes into liver, morbidity, and so on, and kidneys too? You're certainly getting better retrieval than anybody else in the world at the moment in respect of lungs with your protocol. And the second was, what prognostic tool are you using in intensive care to prognosticate the likelihood of progression to circulatory arrest?
Well, the first questions, our results with abdominal grafts using thoracoabdominal NRP has been pretty good. I mean, the results are quite impressive. If I will recover only abdominal grafts, and my donor is only available for liver and kidneys, I do think the abdominal NRP, my personal impression, is easier than the thoracoabdominal NRP. Up to now, I have done in my own center 17 procedures of thoracoabdominal NRP. Around 300 with abdominal NRP. So I have more experience with abdominal NRP. I feel more comfortable with this procedure. I think it's easier to go further with abdominal NRP than with thoracoabdominal NRP. So my personal point of view is that if I'm going to recover only abdominal grafts, I do prefer abdominal NRP. The combine of lungs retrieval with rapid recovery technique plus abdominal NRP is very easy. I think I don't see any kind of complication, but we are still having some kind of problems with thoracoabdominal NRP because we are not sure that the heart is going to be good enough to pump by itself. So I think thoracoabdominal NRP is excellent if the heart is going to be recovered or transplanted, but if not, I wouldn't use thoracoabdominal NRP for all abdominal grafts. That's my personal point of view. Secondly, about the intensivist. I think that we must consider that we don't have enough skills to predict if one patient is going to die in a short period of time. There are not this type of methodology. It's the personal impression of the intensivist who can think that it's going to happen or not, because all the tests that have been described are not very useful. But I have to emphasize that we must think about to have the palliative care of the patients and the use of drugs, sedative drugs, analgesics as part of end-of-life care. And that's very important. We don't consider in Spain or in France that once you have decided that the treatment is futile, that the best approach we can give to this patient is to comfort care, we are not going to withdraw lysosomal therapy without any kind of analgesic drug or sedative drugs. Is not fair. This type of drug, this type of treatment is part of the end of the life care of the patient, no matter if they are going to be donors or not. We use the same drugs for those patients. We are not able to become donors, but we are using this type of care in the intensive care units. I think that that's the most important thing. Of course, in those cases in which the period of time is so long, we have the NRP to recover the ischemic damage observed during this long period.
Thank you so much, and congratulations for achieving the dizzy heights of over 90 donations per million population and a DCD conversion of over 50, which is just incredible. Any questions from our international? Anybody here have any questions?
Thank you. We'll go to the next.
Well, Professor Menendez, thank you so much. We'll continue on from here. Thank you.
Thank you, Kumar. That was really fantastic.
So we'll now go on to the next session. We will cut it down to about 30 minutes because people have flights to take. And we won't try repeat much. So I'll now request Ravi to join me here and you can sit, you can stay there because we have to do this. So we have made a national protocol and we'll just try to discuss a few things out of that and take the expert views here. So can we have that presentation? Whatever has been already covered, we'll just skip. Yeah, that was the one. Yeah. Thank you. So we have been talking about brain death for last 20 years. And as we spoke earlier, we need to get on with the circulatory death part. And this is the study we published in 2009 that if there is a devastating brain injury, we see brain death. People die with circulatory death. And I think now our focus needs to shift from those 30% to this bigger 70%. And if we see overall also deaths in the world or the brain deaths account for only 2%, 98% are circulatory deaths. So time to shift the focus, already covered. Does the law allow DCD in India? A lot of people have asked us this question, and we have people joining this meeting from various parts. So just to cover the basics, yes. So the answer is yes, because in our 1994 law itself is said that organ donation can be done in brainstem death or in a cardio. Form to use for consent, do we have to create anything special? Again, maybe more by accident than design. In our Form 8, again, it was there. We could do either in the declared brain complete dead. So we have the legal structure already in place. What categories of DCD are feasible in India? If anyone here in the panel or you could quickly like to comment.
So type 1 and 2 are going to be difficult because, it's an uncontrolled situation and we don't really have the kind of infrastructure to revive patients or do good quality CPR at home or in the community. So we are at this point looking at category 3, 4 primarily and maybe to some degree 5 also.
Thank you. So just to show that we thought about all this in 2014, and I wanted to project this slide. Kumud is here, Marty is there, Darayas, you are there. 10 years ago, we held this meeting, and we are still talking about it, but I think a lot of distance has been covered. We are almost there now with everybody there. So 2022, we have already published our first guidelines, and everyone can go through in India, whoever wants to do DCD. And the good thing we did was that in our country, the problem is there has to be a 6-hour interval between the first set and second set of brain death tests. A lot of people we lose during these 6 hours. And some people were doing a CPR during this time if there was a cardiac arrest. So the way out we published in 22 was here that if the patient is unstable, we sign a do not resuscitate from the family, and then we don't have to do a CPR in that situation and go ahead. So this was the way we suggested, and it's a good practical solution. Is withdrawal of life support allowed in India? Yes, we have discussed this. And for the people who want to go through, this is now available as a nice paper written by the Society of Critical Care Medicine, Primary Medical Board, Secondary Medical Board, and the process has been made much easier. We have another consensus statement on how this is to be done, DCD in the 3 situation, 2024. So a lot of hard work has already been put. You can see there are 12 societies on the right side shown who are involved in producing all this documentation. and the pathway for DCD4 has already been discussed. Now, withdrawal of life support has started. Maharashtra was the first one to go ahead. Goa also, I'm told, Karnataka. So we three states have already said to start withdrawal of life support, and we are gradually trying to do more and more. But as we just to show you how much is the activity in India so far, we have done 68 kidney transplants DCD, 33 in Ahmedabad, 30 in Chandigarh, 4 in Nagpur, and 1 in ILBS. We have done the first pancreas DCD transplant, which is very heartening. We've tried a few super rapid recovery livers which have not worked. So the obvious solution would be the NRP. We tried the normothermic machine perfusion in 16 patients. It became very expensive, and Organox left the country. Hypothermic, the HOPE one, is still being used once in a while. So the obvious way, as Eduardo was saying, is to go for NRP. And our consortium that we established, we have been at it for about a year and a half now. This is our mission statement, and I think we are ready to publish our consensus. We've met about 12 times so far. So with this background, I'll hand over to Ravi, who will tell you what we have written regarding the next step of WLST and establishing NRP.
So this is the WLST team that will basically initiate the process of withdrawal, and it will include ICU specialists, nurses, hospital administrators, and grief counselors. Then there is the procurement team, which will have the cardiothoracic surgeons, the heart-lung transplant surgeons, sometimes even vascular surgeons. Because even if we are just doing a peripheral or abdominal NRP, we may need their help to put them on the NRP. And then, of course, cardiac anesthesiologists, liver or abdominal surgeons, ECMO specialists, perfusionists who are experienced and trained in this, scrub nurses who are consistently helping us with the same cases, transplant coordinators, just to coordinate everything and are the central to this whole process. We have also designed an additional consent form to go with the process and the documentation for which is required. And we're going to make some minor changes, but this is vetted by legal teams in India who specialize in medical legal cases. So we've basically come down to 3 scenarios in which we may be doing NRP for DCD. So first scenario is like it's more commonly practiced in the US, where the withdrawal happens in the OR and the thoracoabdominal NRP is initiated in the OR. And in this case, the algorithm is similar to what has been discussed so far, which is, prepped and draped in the OR, withdrawal, followed by monitoring, and when the systolic is less than 50, then the functional warm time starts, and after pulselessness, 5 minutes of no touch period, which is also in the same in India, followed by heparinization and change of cannulation, and the NRP is initiated, followed by observation for about an hour, and then if organs are suitable, then go ahead with procurement. Second scenario is when the withdrawal happens in the OR and there is peripheral or abdominal NRP done, which is what is more commonly practiced in Spain. And this protocol for the same will be very similar to what has been described so far, except for the access, which is going to be through the abdominal or iliac vessels. And we have a sort of homegrown circuit which comprises of a ECMO circuit followed with a capacitator and oxygenator to do that. The scenario 3, again, which is more commonly done in Spain or in some other European countries, is withdrawal in the ICU and procurement is in the OR. Now here it will obviously helps to be peripheral NRP through the femoral vessels, and here the protocol is going to include, in addition to after the patient is on the NRP, they'll have to be shifted to the OR for the procurement, and that's going to be slightly different, and also will require the Ebola balloon to be put and verified before NRP started. So those are the 2 differences between these 3 scenarios. But as a country, we will have to be ready for all 3 scenarios, because we'll have different situations in different states, potentially requiring different skill sets to be available. there is a checklist we have made for every hospital who wants to do it. Basically, you just make sure that you have the right infrastructure, right donor is suitable, you have all the legal and ethical approvals, and then you can, as long as you try to complete all the check boxes, you should be okay to go ahead. And then these are becoming more and more standard as to which organs should be used. And most commonly now we have narrowed down to lactates, which are stable or decreasing, and gross appearance or biopsy of the liver to decide whether or not you're going to use them. And again, urine output, and in addition to a biopsy of the kidney to make those decisions for the kidney. So for heart and lung.
Before we go to the heart and lung, we are going to project the animation of the abdominal NRP and thoracoabdominal NRP. For people who missed the morning session, we'll just run the little animation just to show. And thanks to Jumana. Jumana, are you there?
Yes, sir, I'm here.
It'd be nice if you can show in a couple of minutes your fantastic animation.
So you can start with the clicking.
Yeah.
So this is this is the abdominal NRP. You have a cannula in the inferior vena cava running through the reservoir to the pump and back to a cannula in the femoral artery. Through the iliac, we can put this, and we have to clamp the abdominal aorta above the celiac axis prior to starting the NRP circuit. We have the heater cooler unit, that is a hemotherm, to keep the temperature at 37 degrees, and the Secris blender giving oxygen to the oxygenator at FiO2 ranging from 20 to 50, aiming for an SCVO2 of around 60 to 70, and we keep the sweep gas flow enough to maintain a pH and not cause any hypocapnia. So we usually start with 0.5 to 1 and titrate it to meet the ABG PCO2. In the thoracoabdominal, the cannula is in the RA, the access cannula, and the return is in the aorta. To the circulation to be started after clamping the arch vessels and opening the brachiocephalic to air. Insertion of the PA vent catheter only if lung retrieval is planned, and LA vent catheter if heart retrieval is planned. The rest of the hardware is similar. These are both in OT procedures.
Thank you. Thank you very much. That was really nice. Applause.
Thanks.
Makes it so clear. So back to the presentation and Kumud.
Okay, thankfully we've been through a lot of the comments that are made here. They're just salient points. The very first one is really to understand that your entire wait list, your normal wait list for hearts and lungs, are all potentially good for DCD organs. So if you could move on to the next slide, please. The donor selection also remains exactly the same, except for hearts, where currently in the DCD practice, we are suggesting that donors above the age of 50, particularly in the absence of any coronary angiogram, is probably not a wise idea. And lungs, very similar. The issues here are that you can do all this protection of antegrade, retrograde at the time of the retrieval, and that reintubation is absolutely necessary to avoid, as I mentioned earlier, gastric contents contaminating the airway. So lung retrieval in the setting of abdominal NRP, we've just been through that with Eduardo's really wonderful explanation and how they've got a hybrid model because they cannulate early of doing the abdominal NRP, converting it to a differential temperature, and then converting it to general TA NRP when all organs are being taken. So the important here for lungs is that it allows you time to do the bronchoscopy. It's important, if you go back to the early days of DCD, including even with the TA NRP technique, if you look at the data, the number of lungs retrieved were actually quite few. And there were a lot of issues and people wondering why this is happening. Well, hypoxia does cause acute vasoconstriction of the pulmonary vessels and cause an increase in PVR, and hence it's important to vent the pulmonary artery. The other thing is that you really need experienced team to secure hemostasis when the heart and lung team are leaving, and the abdominal should not be faced with continued blood loss and having to further hemodilute the NRP circuit. You can retrieve the heart even in the abdominal NRP setting from direct procurement, but as we've seen, it is exceedingly expensive to have an excited perfusion device, and it's highly unlikely we will have that setting in India. And therefore, I completely agree with what we've been saying so far, that the thoraco-abdominal NRP technique is ideally suited to allow in situ assessment, validation, and then do a standard static cold storage, which has now been shown, validated both in Spain and with some of the centers in the United States. And again, here in the TRP setting, I'd just like to concentrate for the sake of time and open up on discussion with the fact that you do need the perfusionist to be on the ball. It is exceedingly easy. If you don't have, I say this in the Indian context because often these things are taken for granted elsewhere, that we do need to be observant about the amount of flow we're utilizing, what is the level of the fluid in the reservoir, and the thinking and acting time they actually have at various levels of flow and reservoir volume. So to have a level sensor is very, very important. I'll leave it there because I think I'd like to open up discussions more widely, particularly given we've got the benefit of such eminent international speakers here today. Thank you.
Thank you, Kumud. If we can, let's stop sharing the screen. And, after this presentation, we had kept some time for summing up and tea, etc. But people have flights to catch. So what I'm going to do is I'm going to request every person here, everybody so eminent, to give a closing remark and give us the way forward to India. So who wants to start? You have a flight to catch? So Ravi is going to be the opening batsman here.
Yeah, so I think we have come a long way in the last 10 years since we started, and especially in the last 2 years since we have 3 years since we have published some of this. And the way it has to be done in India is very different from how it is done in the West because of resource constraints. And at this point, everybody's comfort level has to be more before we start doing it, and withdrawal is not so commonly practiced, so that has to become a norm. So things like that, but we are there. It will happen very soon.
Thank you. And Ashish, I can see you there in the audience. Ashish is from PGI Chandigarh and has the maximum experience of DCD kidneys. He's done the only DCD pancreas in India. So, comments from you, Ashish.
As was mentioned by one of the speakers, that we're trying to do all the three things together, right? So my take would be to start the process of withdrawal of life support. I think that is where we are stuck at the moment in the country. We can do these NRPs and all. I don't think we've got enough trained manpower and capabilities in the country itself. So right now, I think we probably need to focus on ICUs in areas where there are teaching hospitals, so that this message of withdrawal of life support starts to go in the community. And once that happens, I think then DCD is a natural byproduct of that.
Yes. Dr. Marty, would you like to say something before I get our Director Noto on board?
No, only just congratulate for the progress in the last 10 years that you did. And now is the technique to do, as you see from our colleague from Minneapolis, for the number of organs utilized by the by the results. But again, the key point, as also my friend from the States mentioned, intensive is the point. And the withdrawal treatment with sedation is the point. And then you never will be upset because all the potentials will go on. Then the techniques, whatever you use, will be excellent, no? And just something that legally, and here is Anil Kumar, I recommend you introduce in the future the possibility to put heparin before the procedure, and second, to do the pre-cannulation before withdrawal. That is changed completely. You have the body in the normothermic machine perfusion. The body is perfused. You can calculate lactates. That changed completely our. And remember, to you, only my region, 62% of the cases today are DCD. If ICU people was not aware, these cases will not exist. And Minyambre said important issue. The sedation and anesthesia at the care of the end of life is not only for donation. It's any patient who is futile to care. It's a good for the people to die with comfort, no? Anything you need? Next year we have a workshop in Spain, as Aunis you attend many years ago. Now is in Barcelona and A Coruña because Animal Lab there, and I recommend if some of you wants to join, will be happy for me, and particularly I will invite Kumud Dital, my friend, to join to see the model. Please.
Thank you so much, Marty. Brian, any last comments?
Just to reinforce what Matthew was saying and what Dr. Ashish also mentioned, that the only way to move forward is to involve the ICU. I understand that that's the only way to make DCD possible and sustainable.
Thank you, Brian. Darius?
So I think just to reiterate an earlier point, that there is a issue with trust in India about accepting brain death. So DCD donation provides a unique opportunity to bypass that trust issue that still exists. But you do need to take on board, it has to be ICU driven. And again, I said this before at meetings, really start with a few pilot centers where the environment and the ecosystem is completely geared to this, because there will be lots of enemies out there pointing fingers, and we all know that has been a big challenge. We're a small group of people, and the people who've got views against this are far larger and far more influential.
Thank you, Darius. Chris, any last comments from you?
No, I wish you luck. I think it's a fabulous initiative and wish you every luck in taking it forward.
Thank you so much. Now, some of the issues that Darius just raised, we're hoping as a clinical consortium that we might be able to mitigate that with we've had Dr. Arun Kumar here throughout these meetings, and from his position as director of NATO, I think will help us to actually translate this into a comprehensive clinical program, and we'd love to hear from him in the last few words of how we might go about doing that.
Thank you very much. Actually, what we realized that world has progressed in the terms of DCD donation, and now almost all the countries which are doing well in organ donation and transplantation, they are doing a substantial number, and we are lagging behind. We are realizing that. So we need to move forward, and we need donors. So so definitely this initiative, which is like some of us and particularly we are very grateful to Dr. Avnish Seth and the Most family and the Manipal group of hospitals for so long he has been pushing for this DCD donation, and many of us, Dr. Shroff, Dr. Mathur, and all of you international experts, so they are all contributing. So it's really time that we should be moving in this direction also, and some of the donations have happened. Some of the centers have already done successfully, but the way it has to happen, the more it in a controlled situation after the withdrawal of life support. And we have to also look at that what all antemotum interventions can be allowed in India, which can be acceptable to the entire scientific community. That also has to be laid down. So definitely national level guidelines are required to move forward in this direction. Once the directions or the guidelines are in place for everyone to follow, I don't see any any hurdle then to in implementing this, and we have to move with the way the world is moving. So we cannot be like.
Thank you so much. And finally, I'd just like to come back to get some comments from our very senior clinical experts here in India. I mean, Dr. Mathur, who today only I discovered was doing in his lab animal liver perfusion back in the mid 80s. So congratulations. These are things we're hearing as anecdotes now. But any comments from you?
Yeah. So what Dr. Anil Kumar said, I will take it from there. That it is doable in our country. We have to catch up. See, when brain death law came in this country, and I have got cuttings at that time, how the people, experts in this country said this is not going to work in India. Cadaver donation will never happen. Okay? And Philip is witness to all those things. So we have moved, and DVD is recognized, people are recognizing, and donations are happening. And across the country it is happening. It is not that initially it started southwest, now it is spread all over. So same thing will happen with the DCD. It's a question of starting. The first step is to be taken properly, as we said, that because all this thing which we have done for last 5 years to draw the protocol. Once those protocols are in place, and as Dr. Kumar said, that the national guidelines are issued, the people will be more comfortable in doing these things. Their mindset that is the law against us? Okay, is it ethical? All those can be sorted out. And to begin with, to simplify the things, I think we should start with the type 4, master's type 4 DCD, where the people acceptance will be there. And then as the WLST becomes a norm in the ICU, in the hospitals, we take it to the organ donation. That's what message.
Well, thank you so much. Sunil, any comments, particularly in respect of your position as a founder leader at Bond Foundation and how we might get this education out more readily?
Yeah, I think it's going to take time for the intensive care people to withdraw care. But we have to move forward. And when we started this consortium also of discussion, what at least I realized at that time was that we have to start doing domestic criteria for donations immediately in our country, and that's not very challenging. And there was a lot of resistance to that as well. In fact, even today there is resistance. Last year, 2024, we did about 1,250 DVD donations. Believe me, there would be another 300-400 where consent was given, but donations didn't happen. And that would have been easily DCD donations. And that's where I think the first hurdle is that if there are some guidelines available, that if you have brain death there, you're not able to do the second, apnea test, go for this. If that clear guidelines come to everybody, I think our DCD numbers will increase. Straight away, we will start doing a considerable number of DCD, at least for kidney and liver in our country. Withdrawal of care is going to happen, but it's going to take time.
Okay.
Are we going to wait that long? I don't think so. This program belongs to intensive care, no doubt about it. But unfortunately, not many intensivists are on board with this program because we don't have uniform declaration of death in this country. There's still ambiguity about death itself. So, and most of our program is in the private hospitals. 80% of transplants are done in private hospitals, so there's a distrust as well. 20% are in government hospital. Unfortunately, most of the disease donor potential is in the government hospital. Most of the recipients are in the private hospitals. So there's an equity disbalance. And that's why I think practically to move forward, concentrate initially on criteria 4, slowly graduate towards 3. 3 should be taken up by pilot centers as already discussed. And I think that's the way forward.
Thank you, Sunil. And finally, Philip, any pearls of wisdom before you head back to the US?
So, right from the beginning, I've been sensitive to two things in India, and it's across the world, I think. One is, of course, if you land in any trouble with the family members due to lack of communication, usually misunderstandings. We don't want to have that. We want to avoid that. We want to build up our counseling services. But the second thing is, will these organs work or not? Any program will founder if the organs don't work. Now, what I found is that with DBD, it is pretty darn difficult in the ICU to manage a patient who is brain dead. When I started the program in Kerala in 2013, my first imperative was to get 2-on-1 nursing on the dead patient in the ICU, whereas the living patients had 1-on-1 nursing. So it's so difficult and labor intensive for an intensive care setup to manage a DBD efficiently so that all the organs work well. That problem is not there with DC. So we are actually dealing with a situation which is likely to succeed because it is easier to do for the intensivist. So that is one point. The second point I would say is that we are now able to tell the recipient hospitals, this liver is going to work, which we can never do with DBD. Half the time you open the patient on DBD, the liver is steatotic and you're wondering, nothing like that. You can guarantee this will work. And that is going to be the strength of this program in India. So with that, I would say, great job, Avnish. And all of you who regularly sat and put the consortium notes and the publication, I have to admit that a lot of things I learned from that, and a lot of things are difficult to understand. I just landed in a place where it was easy to do. So that ease of doing helped me, and I would like to translate that kind of spirit. Itna mushkil nahi hai. We can do it. We were excellent surgeons. We were excellent intensivists. And if we decrease the pressure and load on the intensive care, I think they will come up more.
Thank you, Philip. As we saw today, we have the infrastructure to pull this off in most hospitals, tertiary care centers. And so anybody else from the audience, we can't see all of you. So if there's anyone else who wants to make a comment from the people who have joined online.
Rahul.
Yes, Rahul.
Congratulations to all of you. You have done a very nice job. See, I think all of you are right that DCD is the future of the program. If we want to increase the number of transplants, then DCD is the way forward. But one thing that we need to do is we need to delink the death certification and the donation process. So that is one thing on which we have to work. So it's like there is as Dr. Darius said, there is a lot of distrust or a lot of enemies, a lot of people who will point fingers at you. But the thing is, first of all, we need to start certificating dead cardiac death or brain death, and then as a corollary, when slowly, then we need to take it towards organ donation. So that is one thing on which everyone has to work.
One thing that I want to add, sir, like at AIMS Nagpur, when we started our deceased program or a live transplant program, it was in 2023. And within around 9 months, we did the first DCD. So for us, the live, brain dead, as well as the DCD, they all started together. So today, when we did the fourth DCD around 21 days back, now the setup is a bit more mature to accept the things. So what we have done is uncontrolled, and we do want to move to the controlled DCDs. So it's definitely very, I feel that we all should accept and we should move forward. Thank you.
Thank you. So with that, I think we'll close the session if it is okay, sir. So thank you very much to Marty, Brian, Chris for hanging in there. Thank you very much for your presentations. We loved them. Eduardo, we can't see you, but enjoyed your presentation. And thank you to everyone in the room for sparing your time. Let's take this forward. And I can see the energy happening all around. So we'll see you all more often. Thank you very much. Bye-bye.
Thank you very much. Goodbye.
Bye.
Bye. Bye.
Not to be right. Facing us together and holding us. Yes, yes.
Please, Dr. Mouse is here. And we've been talking about